Good morning. I'm Stephen Tebri. I'm working at Tamale Teaching Hospital, and I'm a surgeon by profession, a general surgeon, and I'm the Dean of School of Medicine. So really, as a surgeon, we don't normally do something like treatment. We go there, either we are able to remove it, or we are not able to remove it, and then we give you to the internal medicine specialist to manage further. So what we're going to do has nothing to do with surgery. I'm going to try my best to put out my surgical ideas and philosophy, and then try to manage and treat patients with this all-important topic. Before we start sharing the slides, I'm going to talk about the rationale, the rationale of the training, and then overview of Transthyretin Amyloidosis and genetic counseling. Just overview of the introduction and the rationale. With any disease in the world, if you don't want to go to surgeon, or if you want to go to a surgeon, if you want to come to me earlier for me to give you treatment, what it means is that we have to start with early detection of the disease. But then how do we detect? First is to do training for people to be aware of the early signs and symptoms. And sometimes you don't wait for early signs and symptoms. Sometimes you do what is known as screening. And I think we've all, as a healthcare professionals, we've heard about screening in some diseases. For example, breast cancer, you have to screen, you have to examine, you have to do self-examination, and then you move on to the next stage. That the aim of that is for early detection, even when there are no symptoms. And then you start treating or managing disease before it progresses to a stage whereby even if you treat, you are not going to get a desirable results. So the same thing applies to, and recently I think we've all heard about prostate cancer, because prostate cancer is very common. We have screening programs for colon cancer, where colonic CA, for example, in the high and middle income countries, UK, Britain, UK, and America. UK and other countries, they said, okay, at the age of 50 years, you have to do colonoscopy, even though you don't have symptoms at all. The purpose of that is to early detection and treatment. If you go to Japan, because gastric cancer is so common, at certain stage in Japan, they will ask you to do upper GI endoscopy. The purpose of that is that they want early detection. So we zoom down to raising awareness to support early detection and diagnosis of Transthyretin Amyloidosis in Ghana and West Africa from public and health professional trainers and trainees perspective. So we are gathered here, nurses, doctors, even including surgeons, to create the awareness, what is it, and what we can do in our capacity for us to detect this condition using various methods. Be aware, because there is a saying that anything that is not on the mind, the eye will not see. So maybe there may be someone in this room I know very well, but if I don't have perception or highly idea that, oh, I'm going to meet this person in Kumasi in True Vine Hotel, I may see you and then I may pass by because it's not on the mind. So anything you don't think about, the eye will not see. So the idea is for us to start thinking about this condition, so that if someone comes to you with some diagnosis, maybe early hypertension, you say, hey, you are 29 years, or you are 25 years, or you are 20 years, but you've developed hypertension. Wow, where could it come from? You start asking history. Has your parents, relatives, grandchildren, grandparents suffered from hypertension at early stage? And we do that mostly for most diseases. So what it means is that once we have this at the back of our mind, I think the first time I heard about it, I said, hey, wow. So early hypertension, these strokes that are common in Ghana, most people suffer from stroke, from cardiac complications. And I said, oh, wow. So maybe that is why we are talking about a lot of things, that we are stressed up, we get early childhood infection, and that leads to fibrosis of the arteries, and then the heart itself. So we say we eat a lot of salt. People are now not abstaining from salt. But still, we get issues and it's on the rise. Hypertension. The question I was asking myself at that time, oh, maybe this is something we are not thinking about and we are not looking at. So it's a great opportunity now for us to start having ideas, start thinking about it. And then once we have the idea and we start thinking about it, what it means is that we're going to have mechanism. Maybe this project will now give us equipment, so that we will use the equipment to detect the condition earlier and start managing. And as we go along the line, you realize that once it gets to a certain stage, then you can't reverse it. But once you detect it earlier, then you can reverse it. So, this is how this session, we're going to have introduction, rationale, and that's what we are doing. We're going to have screening to detect the disease, and then diagnosis to get the diagnosis right. And then in the first session, clinical significance, that once you start developing clinical signs and symptoms, then it means you are there. But the purpose of this gathering is not to get there. But then, if someone has a late disease and you can't even manage it, someone will ask, or most people will ask, why do you do that? Why do you want to, even if you cannot treat it? It is important because once we know it, and we know that it's got genetic basis. Once we know that, it means that definitely we know that, oh, okay, you have the disease. It means that your children and other people from your first line or second tree of line will also have the disease. So then let's go and screen them and see that we will be able to help them, even though we are not able to help you. And I give example with all due respect. Please forgive me if I make a mistake. Religiously, if you come to where I work in Tamale, they say no postmortem because we are Islam. So once something happens and you pass on, by 3 o'clock before the sun sets, they have to send you to your grave. If you come to where I come from Sunyane. Where I come from is party. They have to put you in the fridge for a long time. Nobody touches you. Even if there is postmortem, because yes, the dana will not get the money, will not get the funding. And it's worse in Ashanti region. Okay? So don't do that. But then I asked myself, even in Saudi Arabia, where the Islam originated from, they have pathologies there. And they perform post-mortem. We as a people, by our culture, by our religion, don't believe in post-mortem. But that's why you develop a condition that is genetic predisposition, but nobody will know. Straight away you go. What happens to you? No post-mortem. It's expensive. Don't do it. We are denying generations upon generation, even your own generation, about some condition that would have been treated earlier and help your children to live longer, to see their grandchildren when they are on pension. Because in other jurisdictions, when people are on pension, that's where they enjoy life. And then carry and have time with their grandchildren, surrounding them and enjoying the life. But there because we don't do all those things, 56 years, you are gone, 40 years, you are gone. You see the poster everywhere. Gone too soon. What a shock. All these things comes along because of the fact that we don't do the right thing. The culture is preventing us. And culture is dynamic. If in the olden days, we were not putting cadavers in the fridge for a long time. Now technology has come, fridge is there, so now, long time. Wasting money, wasting resources, but we love to do that. Can we change that culture based on that? So that we do post-mortem. If you go to medical schools, it's very difficult to get a cadaver even to teach medical students. Because the culture will not allow us to donate. Recently, we wanted to do a course in my medical school for those who are going to Ghana College to be trained as surgeons, OBGY. And we're looking for a female cadaver. You know, women are so important. So if the children are not going to take care of the husband's relative or her relatives, but for we, the men, you can always get it. So we call all the centers, the mock. We said, oh, unfortunately, we can get you a male cadaver, but we cannot get you a female cadaver. But these young doctors who in the near future will treat us and treat our children will not get the female pelvis to be trained to become top-notch OBGY specialists. So where are we going then? So that's why post-mortem, and I said, I'm saying all this because the clinical significance, even when you detect it, it is also better even if it is late and you can't treat it, even at death. You need to do the diagnosis, identify it, and then help the future generation. So you see that everything we do in this country is not for the future generation, but it's for the current generation. So how are we going to survive as people? So that's why even though you develop the clinical importance, nothing can be done, but it's still necessary to do it. Then the other thing, confused? Oh, help me. The other thing we're going to do is a final one and say what we're going to do. So because I want this to be interactive, because I'm not doing it alone, we are doing it together. If someone has got a question at this point, you ask if you have something to add to what I say, what I've said, to buttress it, so that we all agree in this room that there are some decisions that we've been taking as people based on culture, based on religion, so that we move forward together. So it's not me alone telling you. Some of you have got experience more than me, and it's better we listen to you. So please, if you have before the technicians, so I think the first type is to know about within the decades, the report and three most common type. And then collaborative effort. That's why I say we are together. We are in it together for early detection, diagnosis, and treatment. So before I move on to the actual lesson, if you have anything to say, if you have anything to add, any comment, anything at all is acceptable because we are together. Do you have another microphone, sir? Yes, please. If you have anything to say at this point before we move on, please go ahead. Don't feel shy. Feel free. We are in it together. It's an experience. It's something we're going to tell you. But we want it to be as interactive as possible. So it's not always me talking or the moderators or the presenters talking, but we can work together in this field. So please. Yes, madam. I can see from your smile and body language that you want to share something. Please go ahead. Anything at all, please. Yes.
Maybe it's here too early.
Sorry?
Maybe it's here too early. Maybe it's here too early for them.
Oh, okay. It's too early. But share lifetime experience. Yes. Thank you, sir. Please, your name. As we go along, we will know each other. But if you say we're taking, so once you have something to share or something to say, please mention your name and where you are coming from. Which institution? Thank you very much, sir.
My name is Dominic Akateba. I work with Kolebu Teaching Hospital and the Upper West Regional Hospital.
Welcome.
Thank you, sir. Thank you, Prof. So I was just going through what we'll be doing, like the various sessions, and I see a lot of emphasis is on like the effects of ATTR on the heart and all of that. One glaring omission I see is the renal component of it. I'm renal biased because I'm doing nephrology, and we have a couple of patients who do present as such. I've even had a paper out of one of those amyloid presentations. So I was wondering whether we overlooked that, or maybe it's not something that we see in our African context. But I don't know if it will come up. But from what I see that that's left out. That's just something I wanted to find out. Thank you.
Thank you very much, sir. That's an excellent and brilliant contribution. Please, organizers, please put this one down. There was a mention on its effect on kidneys. Okay? So I think we had a specialist who was going to talk about from your hospital, but unfortunately, for some compelling reasons, he's not going to be here. But thank you so much. I think if it's not going to be looked at, then in the near future, you and your team will help us. Or maybe along the line, if I may beg your, if I may ask for your help, if you've got special experience when we finish other things that we are doing, then you can share your experience with the kidney, the effect on kidneys. Thank you very much. It's an excellent contribution, because maybe we are getting a lot of renal failures now at early age. Yes, it can have a serious consequences on the functions and then the damage to the kidneys. Okay, if you go to all the renal centers, nephrology centers where they do dialysis, you see people from all ages. Okay, so thank you very much. That's brilliant contribution. That's why we want to hear from you, please. Any little thing helps. You see that Mr. Dominic has changed the dynamics, and he has now given us advice, input that will help in this work. And this is what we want to do today. Yes, any other person, any experience, any personal lifetime experience, you can share something about the fact that maybe some disease and the person passed on, is buried, and then, or he's gone but still you see the disease going through the family tree. You can share that. For us to strengthen what we want to do, please share that. Share all your experiences in your work in terms of genetic predisposition of diseases that you have encountered in your practice. We still have time. Please think about it and share something with all of us for us to learn. Because we said we are doing collaboration, okay? And we are working together to find out a solution to a problem. So your personal experience at home, in your community, in your hospital, like Mr. Dominic has done, is very, very helpful. And it will help the team in planning future work. Yes. Okay. Please think about it. It's not going to be too late. At any point, if you want to share it, please go ahead. You see, I'm born before. Please help me. Okay, next slide, please. Okay, it's here. It has changed. I need to point it. Okay. So this session gives a brief overview of the project, its relevance in Ghana and West Africa, the overall goal and objective of the training, focus review of the Transthyretin Protein and its role in amyloidosis, and the relevant diagnosis, driven knowledge of the Transthyretin Protein. Now, do we have our West African colleagues here? I think, yes. Thank you. Special welcome. Please introduce yourself and tell us which country you are coming from. Thank you. Nice to see you.
I'm also nice to meet you, Professor. I am Professor Melanie from Côte d'Ivoire. I am renal physician as Dominic, and I represent the program in my country. I am from Bouaké. Bouaké is 200 kilometers from Abidjan. It's the second big region of Côte d'Ivoire. And I'm very glad to be in Ghana. It's my first time in Kumasi. And I'm so impressed by the topic of the speech of the Dean. Thank you very much.
Who speaks French to welcome her in France? In French? Yes. Who? Yes, sir.
I speak French or English. French? French? In French language. Okay. Je suis le professeur Bengali Traoré de la Guinée, Conakry. Pour ok. 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 Donc, je vais parler au nom des Ghanéens pour vous souhaiter la bienvenue dans la belle ville de Koumassi, une ville avec un bon climat, moins de pluie comme à Conakry et à Abidjan. Voilà, et un peuple très accueillant. Bienvenue.
So, say, Professor, so now it's your turn to introduce yourself and tell us where you are coming from. Thank you.
Okay, my name is Bangali Traore. I'm professor in surgical oncology, general surgical oncology of oncology department at Conakry University Hospital. I'm also the coordinator of National Cancer Control Program of Conakry. I'm happy to be here with Kwaku. Where is Kwaku? Okay. Voilà, I'm happy to be here. Thank you.
So you see how we are working together with our partners in West African sub-region, but there's something, personal advice and personal experience I want to share with my Ghanaian colleagues here, especially those who are young and those who are still in school. You all know VAT. What is VAT? VAT. When you go to buy fuel, yes, you know what is VAT. Please tell us. Yes, give the. Yes, please make the microphone available, yeah, because it's going to be interesting. Our lady said valued added tax. Do you know, as human beings, we also have valued added tax? Do you know we have? You don't know? Wow. Okay. Let me explain. You see, as people, we import cocoa pods, okay, in bags. And then we say we ship 20 tons, 100 tons, whatever. Now, they will. Okay. Okay. I'll do that. Thank you. We dig gold. We take with the rubbles and send it, and someone will refine it for us and add values to us and then bring it back to us. So if you get a powdered or a bar of chocolate, it's more expensive than a bag of cocoa, 50 kg. Isn't it amazing? So you sell one bag of cocoa, okay, and it can buy you a bar of Snickers. But the cocoa full bag, 50 kg that you shipped, they take less than a spoon of the powder and turn it into chocolate bars. And then you go and buy the whole box and it can pay for the 50 kg of cocoa. And that is exactly what is happening here as human beings. People have completed school. They say we are not employed in Ghana. They are sitting at home. Is it possible if we learn French, we can get employment in the neighboring countries? And that is a value added task you add to yourself. I go to a lot of conferences all over the world. When we meet the Francophone delegates or participants from surrounding us, they all can express themselves in English. They can come to Ghana and get employment. But we cannot do a return match. Very, very bad. Nurses are struggling. We don't have a place to work. They are sitting at home. Physician assistant. Please put my phone. That's my phone. I'm sorry about that. Physician assistant as far as Boko, Navrongo, Bongo cannot get employment across the country to Burkina Faso or to Togo. Yendi, very close to Burkina Faso. When I go to Yendi, in certain communities, your phone automatically changes to the neighboring country number, and people call you and it becomes international. However, There are nurses in Yendi who hasn't been employed, but they can't cross over to go and work in the neighboring countries. And they are sitting at home waiting for government to employ them. So, madam, that is a valued added task. We, in this world today, we are all marketers. We are marketing ourselves. But if you don't buy yourself, who will buy you? If you yourself, you send yourself to the market and you meet yourself and you won't buy, who will buy you then? So that is why this a little exercise for us to know. I think we have a colleague from Burkina Faso. Monsieur, yes, that is the only thing I can say.
Thank you, Professor. What you were saying was so interesting that I didn't want to interrupt you to introduce myself. So I'm Dr. Ilbudo Adama from Burkina Faso. I'm a cardiologist and I work in hospital policies in Ouagadougou. And thank you very much for welcoming me. I'm very happy here. Thank you.
Thank you. Bienvenue, Monsieur Docteur. Okay, so we have also, as we are going, we have a West African colleague here with us, and the good news is that he speaks English. And I'm sure 99.9% that he will not be able to express himself in French. And that is classical. That is what the mentality and the psychic, the English colonial masters did to us. And that is terrible. That's something that has happened to us. So if you have a little brother in school, if you have a little brother doing nursing, please, if you have a child, please encourage that child to learn French. And he will add more value to himself or herself than only speak English. So I'll hand over to my colleague from Serra Leone to introduce himself in French.
Good morning, ladies and gentlemen. My name is Babatunde Duduyemi. Well, I'm from Serra Leone, but I'm not a stranger in Ghana. I was in this country for over 7 years teaching. So Kumasi feel like home because I was in KNUST teaching for 7 years. So I'm glad to be in your midst, and I believe that our interaction will yield something worthwhile. Thank you very much. Of course. How are you?
Okay, thank you. So it means we have a representative from all the sub-region, and this is going to happen in all countries. Yes, next slide. You also put it off for me. Okay, so the introduction and then the rationale of the training program. This training gives the following details. Overview of the disease and then genetic counseling. So you detect the disease. Once you detect it, you detect abnormalities, then you need to call the family and then give them counseling. That this is what is happening, so your lifestyle should change. Maybe your approach to certain things need to be changed. And then again, creating awareness that you can get these symptoms. Because in our jurisdiction, even if you are 80 years and you die, and you have an old lady at home, that old lady is at fault. So we don't have what is known as, in our culture, we don't have what is known as a natural death. So even 90 years, somebody should be blamed for that. How much more if it's 16 years, 18 years, then that old lady who unfortunately is poor, hasn't got money, hasn't got child to take care of her at old age will always be at fault. But maybe it's from genetics that need counseling. And that will also give us knowledge to improve our life. So screening and diagnosis would propose early suspicion, recognition, correlation of the testing types, symptoms of transthyretin amyloidosis with cardiac and neurologic involvement, and the time from the onset of the transthyretin amyloidosis deposition. So again, that is exactly what we are doing. We are creating awareness and possible screening, and then possible early detection, share the information, and I think, the neurologists and other functions will come in. But still, Mr. Dominic, we're going to need your support. The team will get back to you and your team so that we can put yours also into concert. The clinical significance of transthyretin amyloidosis fibrils and treating transthyretin amyloidosis, early detection and treatment. An account of records detailing the distribution of original studies of ATTR-WT, TTR V30M, and TTR V12, I think it's I, in the PubMed database. So we're going to compare the information with the existing information, because there may be information about black people, but the black people that they are talking about is not the original indigens of black people. Okay? Because if they do it in America, they are likely to get third or second generation. In Britain, it's second or third generation. But the indigenous Africans, there may not be information. So there will be a comparison. But please don't ask me the genetic terms, because with all apology, I'm a surgeon. So once we get information about us, we are the indigens. There's no change in diet. There's no change in the environment. So ours will be the original compared to those with the second and then the third generation. So we'll give the original information for people to learn about it. There are certain diseases, even if it's a second generation, third generation, fourth generation, it's same. When you look at prostate cancer, when you look at fibroid, it's common irrespective of the generation of black people from in America or in any high income countries. It's the same. But there are other things that is different from the indigens compared with the second and then the third generation. So we will provide this information so that we can get something to compare with the existing database. Then 5 strategies to promote physician-pharmacist collaboration to facilitate early detection and diagnosis. Healthcare has been a teamwork. But I think recently in Ghana, what I'm seeing clearly is that each and every one of us want to be at his corner. And that's my territory. Please don't cross. So you see, I think I've seen one of my colleagues from Tamale Teaching Hospital here. You see the nurses have their territory. If you are crossing and you are not careful, they will deal with you mercilessly. The same way doctors have their territory. Physician assistants say, no way. We don't want to work in collaboration. We want to work independently. Anesthetists say, no, we don't agree. We're not going to do that. But healthcare is a collaboration, teamwork. I can't work in theater without preoperative nurse. How do I do that? Sometimes when there is a cannula, in order not to insert in a cannula because I've done it long time ago, I'll call him to say, oh, I won't say I don't know how to do it or I've forgotten. I say, Master, go and do it for me. And then he will also say, well, you know what, I'm a nurse. I'm not supposed to do that. It's a collaboration. And wherever I go, I always tell a story. It's not a story, but it's a fact. Usain Bolt is the fastest man on earth. Is that correct? There's no doubt about that. None of us in this room will argue that Usain Bolt is not the fastest man on earth. But let me tell you that Usain Bolt is not the fastest man on earth. Put Usain Bolt in collaboration with 4 men. And each of them is running the 100 meters. Put them together and they believe in absolute collaboration. They beat Usain Bolt's record by 37 seconds. If you like, check. What does that mean? What it means is that when we work together, we beat our individual records. And we believe in absolute collaboration. We beat our individual records. That's a fact, and that's what happened. So if you want to people say if you want to run fast, etc., people have got a various way of saying it. But the fact on the ground for us, all of us to see, is to compare Usain Bolt's record for 100 meters and then compare with Usain Bolt running with 4 men who believe in collaboration. Each of them is running 100 meters. If you strike the average, total, they beat the record of Usain Bolt by 37 seconds. So Usain Bolt is not the fastest man. But if he's in a collaboration and he's running the same distance, he beat his own record by 37 seconds. Isn't it amazing? Amazing. So how can I say I can work alone as a surgeon without a nurse? How can I say I'll do surgery without nurse anesthetist? How can I say that physician assistant will prepare the patient, talk to me, work with me, and said, okay, you've done this, go and do this, do this, do this, do this. And then we work together in a team. And let's see our achievement as a team, rather to say that, oh, okay, I want to work independently. Independently. If you go to hospital, do you want only physician assistant to work on you? Do you want only a surgeon to work on you? Do you want only the nurse anesthetist to work to get your surgeries done? I don't think you wish it for yourself or you wish it for any of your relatives. But because of ego, because of, oh, okay, I'm also there. I don't want to work with you. Let me work independently. That can never happen in the healthcare because you don't want a physician assistant or a surgeon, myself, to work alone on you. Being the scrub nurse, being the nurse anesthetist, operating and also doing and checking the vitals. You don't want that to be done to you. So why do you want that? It's ego, but we have to deal with our ego so that we work in collaboration to facilitate. Next slide, please. It's not going. So, okay. I finished. I think this is the last one. The last one, is it? So, in concluding with the introduction, before I take questions, the overall goal of this training is to promote early detection, diagnosis, mitigate misdiagnosis, timely treatment of the condition in Ghana, and not only in Ghana, and then to collaborate with our colleagues in the West African sub-region. In anticipation of creating robust West African Amyloidosis Center, I don't know where in Navrongo, but never mind, is all in Ghana, whether it will be in Navrongo, Accra, Kumasi. We don't care. What we care is to get the treatment. In the long term, for a sustainable and contextual, research-driven ATTR amyloidosis, healthcare, and education. Thank you very much for listening, and I'm very grateful. I'll take questions before I'll take my seat. Okay, thank you so much. Without much ado, I'll call on the organizer to introduce the next speaker. Thank you.
He deserves a bigger hand. All right. Prof. Tabiri, we are grateful for the overview. I have started learning, and I know we are all picking one or two. Without wasting much time, I will call on Dr. Kweku Apiakubi to take us through the next session. Let's welcome him with a hand of applause.
Thank you very much. Good morning. Yes. Prof. Tabiri has said it all. And this is what I will be doing with you. We will discuss an overview of Transthyretin Amyloidosis. And these are things I expect you to take home. The essence of the whole exercise is to enable us support early detection and diagnosis of transthyretin amyloidosis. To do this, we will need a strong background in the disease to help us appreciate how we can plan and undertake diagnosis of the disease. Firstly, we want to know what amyloidosis is. In broad terms, what is amyloidosis? That is what we want to discuss now. This has to do with protein misfolding. And we all know there are many different kinds of proteins in our bodies. These proteins have important roles that they play. Transthyretin is one of the proteins that will often misfold in humans and other animals. But of course, our focus is on humans and not other animals. So all that I will be saying will be centered around humans. But the question is, what other proteins will misfold? And that brings us to the point 2. please, let's continue. Let's continue. So here we are looking at about 42 proteins have been identified to misfold, leading to amyloidosis, which is a group of diverse, progressive, degenerative, life-threatening diseases or complications. But we need to note one thing. We need to note one thing. The proteins are obviously in various parts of the body. Not so? Right. So, if the protein finds itself in, say, the heart, if the protein finds itself in the heart and causes some complications in the heart, that is just a particular place, right? But this does not make it localized. Proteins are produced from certain parts of the body. So the part that produces the protein, if that part is affected, then we say it is localized condition of amyloidosis. But then, if a certain part of the body produces the protein, it does not mean that that is the only place the protein will be found. Proteins will move in our bloodstream to other parts of the body, or organs, tissues. Once that happens, then we are looking at a systemic situation where other organs, other than the organ that produces the protein, are also affected. So with this, we can put amyloidosis into two sets, where it is happening within the organ that produces it. We say it is localized amyloidosis. But when it goes beyond the production point to other parts or tissues, organs, then that becomes a systemic form of what? Amyloidosis. 22 forms of protein are involved in what amyloidosis here. Now we want to look into the misfolding bit. What accounts for this? What causes the misfolding? Is it a miracle? Is it spiritual? Of course, in the scientific realm, we have realized that protein misfolding here has to do with aging. As we age, there are possibilities that the proteins might misfold. That is one. Then also, it could be as a result of gene mutation. As we all know, proteins are products of our genes. So, in some instances, if there is a gene mutation, I will be discussing this in details as we move further. But when we have issues of gene mutation, then that can also cause the proteins to misfold. The very last thing is, if it is not mutating, then it is also possible that we might inherit the mutation. So these are basically the causes of protein misfolding. In addition to that, we can have instances of chronic infections and also inflammatory conditions or diseases. These could also cause proteins to misfold. Next thing we want to discuss is, we did say that various proteins are involved. I have mentioned that we are saying 42. How do we name them? especially when the protein has misfolded. How do we name them? Here we will look into 4 most common proteins that misfold, and then use them as examples to learn about naming. When the protein misfolds, we say it is an amyloid protein. When the protein misfolds, we say it is an amyloid protein. Next slide. So here we will talk about 4 main types of proteins that often misfold. The very first one is what has brought us here, the transthyretin protein, the very first one. So, normally transthyretin protein is abbreviated TTR. As we progress, you will appreciate why it is TTR. And so, amyloid, TTR misfolds. So we have A as amyloid. And then the protein is TTR. So it becomes ATTR. Thank you. It becomes ATTR. Then we have light chain antibodies also possibly misfolding. So we will have an amyloid light chain antibody. Then AA has to do with the protein misfolding associated with chronic infections and also inflammatory diseases. Normally the A is serum A protein. And so we have amyloid A protein, making it AA. And then the very fourth one is the leukocyte chemotactic factor 2. That is a normal protein. Once it misfolds, it becomes amyloid. So we have ALEC2 or ALEC2. Please, I hope you are following. Next thing we want to do is look at how these 4 common protein misfolding can give us 5 most common amyloidosis. The transthyretin protein, as we discussed earlier, could be folded as a result of aging or mutation. Based on this, we can have 2 common types of transthyretin diseases. Wild type is the result of aging. And then we can also have the hereditary transthyretin amyloidosis, which is the result of gene mutation. We have light chain, which is AL amyloidosis. We have AA amyloidosis, and we also have ALEC amyloidosis. So the 4 most common protein misfolding will give us 5 common amyloidotic diseases. Hello. Next is, as I mentioned earlier, are these diseases systemic or localized? What we should be looking at now. For ATTR, mostly we find them mainly in the heart and the nerves. But in addition to the heart and the nerves, we will find them in the kidneys, in the ligaments, in the tendons, gastrointestinal tract, the eye, skin, and even in the lungs. For AL, we will have them in the heart, in the kidney, some soft tissues, the liver, nerves, gastrointestinal tract. The AA is primarily in the kidney, mainly in the kidney. But then, we can also find them in the liver, the heart, gastrointestinal tract. ALEC is mainly in the kidney and the liver. What does this tell us? They are systemic amyloidosis. They are systemic amyloidosis. Having discussed this, we will zero on transthyretin protein or transthyretin amyloidosis. To appreciate this, let's learn a little about the protein. To appreciate this, let's learn a little about the protein. First, the protein was first found in 1992 in the cerebrospinal fluid. And looking at the nature, it was first called prealbumin. But as work continued, and I'm trying to look into the function of the protein, how it works. These are the observations that were made. The protein is involved in transporting thyroxine and also retinol. Retinol, we all know, is vitamin A. So with this in mind, okay, if the protein will transport thyroxine and retinol, then we have transport thyroxine, retinol. So we have transthyretin as the name of the protein instead of the prealbumin. That is it. Now let's do some biochemistry here. The protein has 4 identical units. 4 identical units. What it means here is that identical will be homo, and 4 will be tetra. So the transthyretin protein is a homotetrameric protein. Now, each of the subunits, 4 subunits, each is about 14 kilodalton in weight. And if we say we have 4 of them, 4 times 14 will be giving us about 56. But then, averagely, the molecular weight of the homotetrameric protein is 55 kilodalton averagely. And now, production point. Where is the transthyretin protein produced? That is what we want to look at now. The bulk of the transthyretin protein is produced in the liver. Over 90% of transthyretin protein, TTR, is produced in the liver. The rest is produced in the brain and also in the eye. Are these points important to us at all? As we advance, as we talk, you may appreciate why it is important to note the production point, especially in diagnosis of the condition. Again, Protein, as I said earlier on, we can't talk about proteins without looking into the genes. Genes are products of what? Protein. So here, the TTR gene comprises 4 exons and also 5 introns. And it is located on chromosome 18 at position 12.4. Of course, the base pairs around these reference points. Now we want to look into how the transportation of thyroxine and retinol happens. That is what we want to look at now. There are some binding points for thyroxine protein on the TTR protein. There are sites where thyroxine can bind. That is not all. Also, we have the retinol binding protein that forms a complex with the TTR. A retinol binding protein, RBP4, will normally form a complex with TTR. Once this happens, the weight will go up to about 76 kilodalton. Can we make some deduction here? If we have 76 kilodalton, and we know TTR is 55 kilodalton, then obviously the RB, that is retinol binding protein, is about 21 kilodalton. So once we have a complex, that is what happens here. Other information that we need to note is the average human plasma levels of TTR is about 0.25 grams per liter of blood plasma. And also the RBP4 is relatively stable in the blood plasma, and we have concentrations of 3 to 4 milligrams per 100 mils of normal blood. This information might look boring. The information I am providing might look boring to you, but we will appreciate it if we move. Now we want to dig further. We just say transthyretin will misfold. What are some of the factors or physiological conditions that can cause the protein to misfold? At pH, low pH, say 5.1 to 3.9, can cause proteins to misfold. So under these conditions, the protein becomes a little unstable. When pH is low, the protein can be a little unstable. Not only this, aging under aging conditions too. So gradually, a tetramer will begin to become unstable. It can break down. So we have tetramer breaking down into dimers, and even dimers breaking down into monomers. That is what happens. And then they begin to aggregate and form fibers. still on of course. Normally when you look into protein, there are C-terminal point and then N-terminal point. You know? Yes. Very, very important. Based on these, we can have two main types. Type A is predominantly made of C-terminal fragment and then also a full-length ATTR monomer. This can be very, very helpful in diagnosis. Knowing that type A will have a C-terminal and also a full-length monomer, that gives us type A. For type B, we have only the full-length ATTR amyloid fiber. This information really helps us in diagnosis. And say type A, we know is C-terminal plus the full length. And type B is just a full length, right? So with this information, it helps us explore drug designs and also helps us to comprehend diagnosis. Drug design, comprehension of the fragments will help us in diagnosis as well. I hope you are following. Please, are you following? Let's go. Let's move on. So still on transthyretin protein. As we advance, I realized I have to place the mic close to my mouth. This is what I. So Congo Red Dye. We will talk more about it. But this Congo Red Dye, some observations have been made for type B. Type B. And affinity. Strong affinity for type B. So what it means here is that with type B and Congo Red, easy to detect. Then also with please for now that 9IM TC DPD scintigraphy has been shown to have a very high affinity for type B than type A. Then when it comes to this CPIB PEP scans, this time A is easy to detect. Next slide. Just so we appreciate the structure. We did say 4 identical units. You remember? see for identical units. Homo, but they look alike somewhat. Monomers, 4 identical monomers. So we enlarge just one, and so we will see some beautiful strands here. But the strands run antiparallel. Yes. And these loops, especially the CD loops, often affect stability. So issues of stability here will cause the protein to misfold. This is a way to help us appreciate protein misfolding. As in, we talked about genetic factors, we talked about aging. So, chiefly protein TTR synthesis here. We have the liver producing the bulk of it, the brain, and also the eye are involved. But in the end, remember this. Do you recall we talked about pH, low pH? When pH is low, all these things, very nice homotetrameric protein eventually misfolding. This is what we have. Misfolded mono. You will find them in various organs or parts of the body. So that's it. Next slide. Wow. That's it. Two main types now. Hereditary and wild type. The wild type is the result aging. And when we have mutation, once we have mutation happening, that could also, so two main types, as we mentioned earlier. Well, if you read literature, this is what you will often see. Sometimes they write it wild type, WT, and then we have ATTR. Others will write ATTR and then WT, and you are wondering which is which. Please, if you go online, these are things that you will likely see. So there obviously there's a need for uniformity. A need for uniformity here comes to play. We have a nomenclature committee. The International Society for Amyloidosis has a committee, and this committee, most recently, just last year, agreed that we should go with this. Go with ATTR followed by wild type, WT. So this is what we use. Then hereditary. You will find some using H, using V. But the committee decided that we go with variant V. So we will have ATTR and then V. Then organs that are often affected most. The heart, predominantly heart and the nerves are affected most. But it has been realized that ATTR wild type affects the heart more. And the hereditary form, ATTRV, affects the nerves more. So wild type, mostly heart. And then also ATTRV affects the nerves more. So as I said earlier, ISA, Nomenclature Committee, did help. Now let's look into the genetic factor, hereditary form, and the variants. CM is cardiomyopathy. And then we can also have polyneuropathy. With the nerve. So basically, ATTRV, as we did say, is associated with nerve. And let's look into the naming now. Very common one, TTR, valine, changing at position 1, 4, 2 to isoleucine R. But take a look at the positions here. This is 1, 2, 2. And we have 1, 4, 2. And the question now is, which is which? The proteins will mature. And we also have a precursor protein. The precursor proteins add about 20 base pairs. 20 base pairs. So a matured one will go with TTRV22I. And with the precursor, we add 20. That gives us 1, 2, 2 plus 20. We have 1, 4, 2. So depending on the format you want to use, you will find a precursor, TTRV, changing at position 1, 2, 1, 4, 2, I. So valine changes, mutate to isoleucine at this position. We can, for matured one, we can use this. So it's a matter of choice. But mostly you will find TTR V122I. As one. But the variants are many. TTR variants are many. What that means is the amino acids can change at certain points. One of them is, this is just one of over 100 variants. Another common variant is valine changing to methionine mutation. So we have at position 30. But if you want to use the precursor plus 20, gives us what? 50. So we can have P V 30 plus 20. That becomes 50. So P valine changing to methionine at position 50. Next, I think you will find that here. Let's go to the next slide. Next slide, please. Now, take a look at this. So if we are TTR E to Q at 89, then if we add 20 to this, we have 109 with the people. So the question now is about location and which is most common. West Africa is known to have the V122I. West Africa, the V122I is said to have originated from West Africa. And you might have realized that we have Guinea here today. We have Ivory Coast with us here today. We also have Ghana, have Nigeria. They will be with us online. Nigeria couldn't come. But Ghana, six West African countries, including Burkina Faso, Ivory Coast, Ghana, Guinea, Nigeria, and Serra Leone, have an average of 2.5% V122I prevalence. So that is why there's a need for us to come together. Because the variant is with us. But the question now is transthyretin variant, V122I. That's the matured form. If you don't want it that way, you can use P. And that gives us V142, matured form, precursor form. Then the mature, but this mostly you have TTRV22I variant. In other parts of the world, like Japan, Europe, South and North America, you will find this being more common there. But in Africa, the TTR V122I is common in Africa. Of public health significance. Public health significance. Which parts of the body are mostly affected? See, the heart, the brain, the eye, the kidney, the gastrointestinal tract, the ear. And we have issues with erectile dysfunction. Obviously, the variants deposit there. And once they deposit there, the organs were lost their normal function. So, some diseases that the cardiologists, Adama, is Adama with us? Yes. From Burkina Faso. This is what happens. These are some of the complications that will arise. Atrial fibrillation, cardiomyopathy, heart failure, all these things affect the heart. Then when we go to the brain, a host of progressive memory loss, polyneuropathy. Then when we look into the eye, the dryness, opacity, are cues. So screening session, we will be discussing screening. And these are some of the things we should be looking out for. Sensorineural hearing loss also comes to play. Wrist carpal tunnel syndrome. And then we have issues of lumbar spinal stenosis. These are red flags of ATTR amyloidosis. Things that look out for. So, amyloid fiber, deposits, and the complications that come with them. Are we following? But the question now, I want to ask this question. Wild type, hereditary, associated with which of these? Mostly, the wild type is high. But it does not mean that that is the only one. In addition to the wild type, we can also have hereditary affecting the heart. Next. So basically, these are some signs or manifestations. Next slide. Dr. B. Genetic counseling. Genetic counseling.
Thank you very much. I think, is there any further questions, any further contributions to what we've done so far before we move on? If we have any question or any contributions. Yes, please. Take this one.
Right. Thank you. My name is Chris. I wanted to find out if the misfolding have any effect on the levels of the protein, the transthyretin in measured in plasma, and also. Okay. Then also he mentioned that it can have effect on the wrist. I wanted to know if it will also affect other joints or it affect the levels in plasma, the levels of the protein. The second one, I want to know if the first one, if the misfolding of the protein affects its levels in plasma.
Misfolding. As we discussed earlier, we have variants, over 100 variants there. But the levels will increase. Deposits will be more. And this is where the issue is. So I really appreciate this question. As we have deposits, misfold deposits, and the quantities get more, then the disease also becomes severe. Not only in blood plasma, but also in what? Organs that are affected. Say, of course, the circulatory system will carry or transport the proteins to various parts of the body. Now, as we have more of the deposit, the organs are affected more, and lifespan also becomes an issue here. The systems are damaged. Organs are damaged. But we have treatment. We have treatment. But then the earlier we detect and try to manage the condition, the better. That is why we are here. We are looking at, let's catch the disease early, and then we can treat. So, as time goes, organs are damaged. It could be the heart. It could be the nerves. So back to the. It could be the eye. It could be the penis. It could be the ear. So as they deposit more and more time, over time, so if we are able to get it early, as in detect it early detection here, then treatment might help. But if it takes so long, it becomes an issue. Any other question?
There was a second question. I don't know if the effect can be had on other joints apart from the wrist you mentioned.
We are looking into red flags. We are looking into how we can detect early. And we did realize that, or it has been observed that deposits in the wrist leads to carpal tunnel syndrome. And so, if a patient comes with an issue of pain in the wrist, or the joint, the ligaments, if we have deposits in tendons, ligaments, and the patient keeps coming with such complaints, then most likely we may have to suspect that, oh, it could be deposits of wild type, amyloid fiber, or the variant. But the question now is, which variant? Which variant? That calls for testing. We will do screening. For now, I just want us to appreciate the structure and how it affects various parts of the body. When screening, we start discussing screening, we will appreciate it better. Unhealthy lifestyles, no. No. Like I told you, mutation will have nothing to do with taking alcohol. So, It's just this. Maybe I inherited. And then issues of the wild type, as we age, then we may be affected. So it has nothing to do with alcohol. Nothing to do with alcohol. Okay.
Now the question he asks, he says that does unhealthy or risky lifestyles like excessive smoking, alcohol intake have any link to the factors accounting for TTR? So that was the question, and he asked and says that there wasn't any link. The other question, where is it? He's talking about how is gouty arthritis related to ATTR. Then the ATTR, you made us know, transports retinal and hyaluron. The question is, does the misfolding inhibit the transportation, and can it lead to goiter and growth retardation and Serra Leone?
I see you are raising very healthy concerns. But obviously, when the protein is misfold, it will likely affect ability to transport retinol, thyroxine. Yes, most likely. So yes, levels will be affected, and all these should help us. It helps us know that amyloidosis might be an issue. Is that okay? As we did say, they play a role, but once the proteins are misfolded, it will likely affect how they do that. You have more? Yes. Please. What we are saying here is transthyretin plays a role in the transport of vitamin A, and also thyroxine. But when it misfolds, then it will likely affect it.
Yes. The next question is there a correlation between ATTR and prostate cancer? And can radical prostatectomy be used in identifying ATTR WT?
Hello, hello.
Radical proteostomy be used in identifying wild type? We have techniques for diagnosis, but not radical proteostomy. No. No.
Right. So definitely that is not one. Another question is, can amyloidosis lead to cancer?
There's a question here. Can amyloidosis lead to cancer? Amyloidosis is known to be associated with blood cancers, but not ATTR. Some other protein misfolding are associated with blood cancers, like the air, the light chain. Yes, but ATTR is mainly heart-related diseases, cardiomyopathy. And hearing loss. The things I mentioned, these things, eye conditions, ATTR is mainly heart, brain, and all that.
All right, so it has remained known that it can cause other cancers. I'm coming to you. The next question is that you made mention low pH levels can be a predisposing factor. Does taking substances that lowers pH lead?
Low pH will account for misfolding. And when that happens, we have maybe heart issue. The misfolding will cause issues like this. So when pH is low, that could destabilize the protein and cause it to misfold. Once these proteins misfold, then these conditions can happen.
All right. So it's clear that once we take substances that lower our pH level, then misfolding can occur. The next question is, please, I would like to know, does nutritional deficiency have a link with ATTR? Nutritional deficiencies.
nutritional deficiency will not cause transthyretin to misfold.
All right, so maybe if we are talking about the known nutritional deficiency, whether obese or under, it's a no area. All right, the next question is the precursor variant different from the variant? That is this different from this?
Oh. When we say precursor protein, the precursor is when you hear precursor protein, it has nothing to do with let me read this question out. Is the precursor variant type different from the variant? As I said earlier on, I think we missed some points. We missed some points, and I need to make this clear to you. We are talking about mutation. Okay? Let's get this right. Mutation. And we want to look into amino acid change. Say valine will change to isoleucine. The precursor bit is to help you count. It's just about count. So we appreciate, say we have V30M. So at position 30, the valine will change to methionine at position 30. But then, precursor here is 20 bases added. So it's up to you. You decide. If you say 50, you are counting 50. I think I think what we discussed, some of us are not getting it. Let me take it again. If you say valine changing position at 1, 2, 2. That is the matured one. But if you want to look at 1, 4, 2, then you are including the precursor. Those just to help you appreciate the difference. So, V mutation. It's a choice. If you want to use 1, 2, 2, then that is the matured form. If you want to factor in the precursor, as in the 20 precursor protein added, then that makes it 1-4. So 1-2-2, 1-4-2. 1-4-2 includes the precursor sequence of base pair. It doesn't really, it's just to help you name
Hello.
them.
Doc.
So when you are reading and you see 1 V 1-4-2, it means the precursor has been added to it. If you see V122I, what it means here is that it is just the matured form of it. The precursor has been taken off. So, just for, can we go back to the slide? Like we talked about EQ.
Doc.
EQ. 89. With precursor, it will be more.
Hello. What we should understand is that, let's take it in a mathematical form. The precursor is like a constant, and it is 20. So when you are naming the rest, if you are bringing the P in as the precursor, then you add the 20 to it. I don't know whether that is better. So it's a form of making the naming for you to know that, is this a mature variant alone, or a precursor has been added to it? So the precursor has a frequency or a sequence like 20. So while the normal variant would have been the V22L, when you add the precursor is 20. So when you add the 20, it takes the middle figure. So you have the 1, 4, 2. I don't know whether that is a bit better, or we should go back to the diagram again. So, yes. All right. So the next question is that, can you throw more light on the effects of amyloidosis on the skin and the immune system, if there is any? Effects on the skin and the immune system.
Amyloidosis affecting skin. It's possible. It's possible. So what we do here is that, for early detection with skin, it's one of the ways to detect it earlier. So skin amyloidosis is earlier. It's a sign that it hasn't gone far yet. I don't know if if we realize that there are issues of amyloidosis and deposit. You will detect the protein there, misfolding in the skin. So that is early enough. It hasn't gone to the heart yet. It hasn't gone to the brain. So early detection, skin, and also pain, wrist. I hope it's clear. So with skin, that tells us we are likely not having a severe form of the disease. At skin level, severity is not, it is not worth quick. We we have been able to catch it young. When we find it, we realize that there are issues with skin.
All right. So one thing we need to know is that there is no organ it can affect. The moment the protein is fold and deposit on any part, that part can become affected.
So the case I talked about that we published, it was, like Doc rightly said, it was a skin as a first manifestation of amyloidosis. Typically it would present with petechiae as well as plaques. A couple of them are non-specific. It may mimic lichen nitidus and all of that. The hallmark of diagnosis, I'm sure, like we'll see, would be about doing a skin biopsy, where they do the Congo red staining and all of that. I'm sure we'll go through it when they do, but of course, it's tissue diagnosis that you would use to be able to pick it up.
All right, so they have done a research on it, so he's just throwing light. It's through what? You get something like petechiae, those rashes, then maybe if you do the tissue, you'll get to know. This is a simple question. Can the slice be shed? Can the slice be shared via our emails?
Of course, we can.
Yes, so the slice will be shared. Last but not
let me make this known to you. We have task N. We are a team. We also have a workforce. They will also form task N in Burkina. And so we are connected. So yes, we will give you slides. But it's teamwork we are doing. So as we catch, we need to do some treatment. So you will get slide. Not only the slide. The work will be published. We are looking into even publishing. So as we publish, we give you the paper. But that's not the whole thing. The whole thing has to do with, we are in the hospital. Patients are coming with issues. You see? So yes, you will get your, the PPT will be made available to you. But we are going beyond just PPT. As like Prof. Tabi told you about the work, we just started. All that I have said is just about the protein. We haven't even diagnosed yet.
Hello. Very last question. We go for our break. Last question. Is amyloidosis associated with epilepsy?
No. Amyloidosis and epilepsy.
Don't say no. If the amyloid this deposit on the brain, it can cause epilepsy.
You have seen.
What it tells us is that anything that is repetitive and we can't get the cause, let's look at the second option to what? It might be amyloidosis. All right. Let's Dr. Kake hand.
Calling your party.
The first time we heard of, even though it has been a word, but when you say anybody, you say amyloidosis, in my school they'll say, that your amyloidosis thing is not interesting. The name is not interesting, But remember, it's prevalence and our setting. And conditions that have been outlined, we have chronic patients in the world that we can't tell whether it might be as a result of amyloidosis. So though the name and then what goes into it is not palatable, but we have to appreciate that even if we use it and then save one person's life, it's very important. It's time for our break. I just want to encourage you to take a good look at your sitting place so that when you come back, you gently go back there and we can continue. So please, you just go out, you get a treat, and then you go for your snack. Thank you. All right. Let me see the time. You know, all right, it's now 11:46. So we'll be back. Hey. Is this time not too much? 12:40. Doc, are we coming back at 12:40? At 12:40. It's 11:50. Hello. We have 1 hour to stretch. Oh, it's too much. Oh. Let's see. Please, I'm coming. No. Can we make it 30 minutes? 30 minutes. 30 minutes. So please, we'll be back at 12:15, please. 12:15, we are coming back to start. When we start early, we close early. And go and rest. Thank you. I collected this around this area. Time up, time up, time up. Hello. You are all warmly welcome back from the snack break. Can we get settled so that we'll start the second session for the day? If we start early, we finish early. Some didn't sleep so that they can have the opportunity to go and sleep early. Yes, I'm aware. I myself. Hey, doctor didn't sleep well, so she wants to go and sleep. Please, let's take our seats. Please, can we start? Hello. As if we have a lot of TikTok between us. All right. So welcome back from the break. We are going to start with the second session. That is what? Screening for Transthyretin Amyloidosis. Some of the questions we were asking, I think if we pay attention to this presentation, we may get what? Some of the answers and even more. So without much ado, help me with a hand to welcome Prof. Tabiri to the floor.
Thank you very much. Dominic, what is your experience? Your issue has been partially dealt with, isn't it? So please share something with us. What was your expectation as renal function, kidney, what is the other one? What you do at Kolebu Teaching Hospital. Initially, we thought they were not going to mention your concern. Now it has been mentioned. So let us know your take.
Thank you, Prof. So I think it's been great. The introductory part highlighted especially what is common to us, and also highlighted the fact that apart from the brain and then the heart, where ATTR mainly, the other organs are also of importance. And a key part that Dr. Apiakubi did point to us was about the early diagnosis using like skin, so the skin biopsy and all of that. So the kidney is definitely highlighted, and I'm glad. Thank you.
Thank you very much. And I think Dr. Apiakubi will contact you for more information so that we all have input, so that it becomes ours, not for one person or one institution to deal with. We all have to come on board. Initially, I thought I was the only surgeon in this room, but I'm happy to say that and introduce you to Dr. Yumanore Osein Ketia, who is also a colleague surgeon. Not special, but just to recognize him and his presence, that I'm not alone. So if I'm misfiring, then you slow me down. Thank you very much, and thank you for your presence. Okay, good. Samuel. Okay, no Emmanuel, Samuel. So he is also a consultant surgeon, and then we've worked together for some time, and it's good to meet him again. As we go along, my TTH, welcome, and then we move on. So, yes, the last session, you asked a lot of questions. That shows that it's becoming interesting. But it's Mutant that is coming out. And of course, anything that is new initially is difficult. But once we are able to appreciate and understand everything, it means that, and we are asking questions, it means that we're going to get over it. It will become normal part, like when you say ECG, everybody knows, chest X-ray, everybody is aware. So we are starting, and gradually we hope that we're going to get there. What I'm going to do is genetic counseling. I always don't like using slides, because when you use slides, the basic understanding. So I'll try first of all to give you overview of how I understand it. Because English language, again, is it's not our, our language. So we sometimes do translation into the local language and do back translation from the local language to English. It makes it difficult. When you are reading for someone, sometimes it's so difficult. So we're starting from where Dr. Piakubi ended. The issue is that we have to detect this condition earlier. And how do we detect it? It means that we have to have a way to detect the abnormal protein. And once we are able to detect the abnormal protein, that means that we've been able to have an idea what is going to happen well in advance. So that is the screening we're going to do. Abnormal protein, how does it run through the family to be able to detect it early and handling it. I think that is all that we're going to do. And once you know that, oh, okay, I have it, what is the probability that I'll transmit or transfer it to my offspring? Once we have this idea and we detect the protein and we know that, for example, I have it, then we look at the probability that it will, my daughter, my sons, my daughters, my sons, and then my grandchildren, how would the disease manifest? And the probability that they're also going to have it. And that's what we're going to do now. So all the talking, all the slides, all the reading, that is what it's going to be. We know we have genes, and we have 22 chromosomes, and then we have the sex one. So this genes, which are proteins, or chromosomes, which are proteins, is going to carry something. And what is going to carry will detect whether I will have the disease or I will not. And that's what we're going to do. So in thinking about it, I said, well, I have to get a partner to do with that partner. We're going to do this topic. I found a partner to do this presentation together. So, Hussein, please come forward. We need a marker. Please give us a marker. Okay. So we'll start. Just when we get there, you help us to do the drawings so that we appreciate it very well. So humans have 23 chromosomes, of which 22 are autosomal or nonsense. Please sit down. Chromosomes. The sex chromosome. Each chromosome contains hundreds to 1,000 genes. They are all proteins, but they are described as chromosomes. A trait is a characteristic that determine the gene. The traits are often determined by more than one gene, and thus some traits result from an inherited or a new gene mutation. So either you inherited from me as my child, or I got it from my father, I inherited it from my father, or abnormal mutation. As we go on, as we grow, based on the environment, the effect of the environment on the system, there will be appearance of an abnormal one, even though it is not existing in the previous generation. Okay? And in context of the trait, ATTR amyloidosis are physical appearance that characterize the disease-causing TTR variants that are inherited, or a new gene mutation resulting in a new disease in the TTR trait variant. So either there is a mutation, ongoing mutation, or by inheritance. The gene mutations involve in hereditary or familial ATTR amyloidosis are genes on the autosomal chromosomes. The next thing to note is that any gene involved is a trait. In a trait is a pair, so you have to get two pairs. So one will be there as the normal, and then the one with the trait. So it can either be a recessive or dominant. So that is all we're talking about. Next, please. Okay, I think it has come. Oh. Traffic jam. So keep it. Okay. Technology is good, but sometimes you hate it. Go. Yes. So the possible traits on a pair genes are normal trait on the pair. Let us represent the normal pair with capital T. So capital T, we said they are paired. So we have two pair, one pair that is T, and we are represented with a capital caps T. Now, a normal trait, an abnormal trait on each pair of the gene, let us represent it with capital T and a small t. So we have one that is without a trait, which is two capital T's, and we have one with capital T and a small t, representing the trait. Now, an abnormal trait on each pair of the gene will be TT. So if you have TT, small TT, that means that you have the abnormal. There's no normal. But if you have a capital T and a small t, that means you have the normal one, and then the other pair is abnormal. Now, the second scenario is called heterogeneous. Heterogeneous is when you have one normal trait, and then the other pair is abnormal. And this is a carrier condition. So he's carrying the disease. He's not going to suffer it, but then he carries it. The last scenario is heterogeneous condition. That is a small t. That is possible genotypes of TTR gene are TT, that's capital TT, small t, capital T and small t, and then we have small tt, as shown in the figure below. We'll get to the figure. Of great concern is whether having just one TTR variant gene pair with normal or non-variant TT gene can cause the genetic condition. Hereditary ATTR amyloidosis is inherited in an autosomal dominant fashion. Therefore, a response to the concern about the normal ATTR allele paired with the pathogenic TTR variant allele can lead to the disease. So what I'm going to do with my co-presenter, which is Hussein, is to start drawing it. He'll draw, and let's see how it's going to appear, because we can't go back to the drawing, the figure, and come back, and it's not interested. So he's going to help me. Please, if you come to the middle, Please help us, sir. It's on it. Okay, so come on the side. Very good. Well done.
So, as Prof has already mentioned, we represent our normal person as TT, capital T. So, this is the normal person, and T with small t. This one has the trait, not the disease. So if we are talking about pair, so if we have to pair this small capital T and this the small t, so we have this capital T and this another capital T. So this one with this one will be capital TT, that's normal. Then we pair this one to capital T with small t. So this one will be trait. And then we have another capital T here with another capital T. So this one too is normal. Then here we have the capital T paired with another small t. Which one too has the trait. So if you look at these people, let's say this is the man, this is the woman. So this one has a normal gene, this one has a trait. So when they marry and the children inherit them, 50% this one is normal, this one too is normal. So 50% of them will be normal children. And then another 50%, so this capital T. Then this one, these are the trait. So 50% too will have the trait. They are also carriers. You see, that's in normal situation. If you are normal and you have another one is carrier, good. So now let's see if all right.
It's okay for now. So sit down. Yes. Any question? So you have two individuals coming together. One is completely normal. He has capital T, two of them. And then you have another partner having the trait. That's a capital T and small t. So if they come together, these are the probabilities. So the probabilities of having a normal trait, which is this and that, is 50%. And the probability of having the gene that is likely to cause the disease is 50%. It means in this case, the T is the dominant. So once you have this, they will not have the disease, but they will carry the gene, which they can transmit to the offspring in the near future. Is there any question up to this point? Either to me or to Hussein. Where is he? He has run away. Okay. If I can't answer, then I'll give it to you. Yes. It's clear. So let's go to the next option. Hussein, please come again. So give us the other option.
Good. So now we are going to look at if both parents are carriers. Let's say they are both carriers. So what is the percentage of children having it, and what percentage of children will not have it? So let's look at that one. So this capital T with small t. This one too, capital T with small t. So let's do our parent as usual. So we have capital T, another capital T. So this child is a normal child in this context. Then we have capital T going with small t. So this one has capital T, small t. So this child is a carrier. Then we have small t here, parent with capital T. So we have capital T, small t, another carrier. Then we have small t here going with another small t. So, so when you look at this one, 50% of the children, this one and this one, that's half. 50% of them will have the trait. This one, this normal, so 25% will be normal children. And then another 25% will have the disease. So this small t, per our definition earlier. So it says small t, that's the disease. Capital T with small t, that's the trait. Capital T, that's normal. So in this case, if you have 4 children, one child will be normal, another child will have will carry the disease. No, 2 children will be carriers, and then one child will have the disease. You see, this parent, but that's not to say that, because what is the name? God in His own wisdom, you may have 4 children, and none of them will have the disease. You can also have 1 child or 2, and both will have it. But scientifically, this is the way it's supposed to be. But God can do other things. Yeah. Oh yes, that one there. We are talking of scientific. Yeah. Oh yes.
Okay. So this is what is in the diagram. But I have a question for you, Hussein. What about if we get 2 with this one coming together to produce an offspring, and then let's see what will happen? That is not what we practice, but try this one, let's see.
All right. So now let's see. Prof is saying if both parents are having the disease, what is the percentage of children having, and what percentage of them will have? Your guess is as good as mine. So Prof just wants to tease us. He knows. So we have small t here. We have another small t. We have small t. Another small t. Then this one too. Small t, small t. So in effect, if both parents are having the disease, 100% of the children will have it. Because this time I'm not bringing God. Prof say we are talking scientific, so I'm not bringing God. So 100% will have it.
Thank you very much. Any question? And let me tell you what happens. So you get a lady or you get a man. Let's not blame the ladies, because we have blamed them a lot. So assuming you have a man, got married to someone with TT, and nothing happens. Then he goes to marry another woman who is normal, and all the children are healthy, as Semaba in Ghana. Baako no de baako no ne fiefo nyinaa yɛ abayifo. That's why all the children have this. So because we don't have, and then we said, yes, mpaebɔ will come in, prayer camp, etc. But if you look at this, it can happen. So with another woman, everybody will be normal. But with this particular wife, all of them are abnormal. And then the blame game starts without looking into it. This is a real threat to our society. But in our society, remember, a man will never cause a crime if the woman is not giving birth as a woman. But maybe it can also come from the man. And the disease can come from the man and the disease can come from the woman. But the weakest partner will be blamed and chastised. But this is a rare implication of science. So if you help me to move it on the side. Master, help me here. So all the next slides I'm going to show is what we've demonstrated. Maybe I have to stop because we finished the topic. Okay? All what we learn now, we're using to identify those at risk, mitigate, and use it to advise as you go for pre-marriage counseling with the church or with the pastor or with the reverend minister. It's not a matter of only a matter of praying, but also remember that there is scientific basis to everything, which the pastor may not be able to explain to you. So what we want to do with amyloidosis is that we want to identify those with the traits, identify possibility of having offspring with the disease. But again, remember, what we've shown is just the scientific basis. But again, they can be, with time, the child has parents who have no disease at all, but due to environmental changes, due to internal changes, there can be abnormal trait that is appearing, and that will start from there. Okay, good. Next slide, please. So genetic counseling. So once you know this, you'll be able to counsel and advise and preempt the future disease. Once you know and understand what we have done. Okay, next slide, please. So this is what Hussein helped us to do. So that is the diagram we were referring to. Okay, demonstrating what we have done as a team. Not someone doing it for us, but we have done it together as a team today. Next slide, please. So you use basic this to screen. Okay, so once you know this, it means that you have to now take sample and detect the abnormal trait and then be able to predict with certainty that is there and you have it in the near future. So we have to prevent it. We have to do something to mitigate before it appears. And remember, we said earlier on that early detection, possibility of treatment, and possibility of preventing the disease. Late diagnosis, well, very helpful for the individual involved, but for the future offspring, we can plan. Next slide, please. So screening 2. I think Dr. Pierre Kubi said it. We need to detect the abnormal gene and use it to be able to predict. All this, over the last 15 years, who have done it. Of course, we all can read. I don't need to read it for you. Okay? But I've been able to give some explanation to what we're supposed to. Next slide, please. Thank you very much. Questions to me and Hussein. Hussein, come. You know, I work with him in theater and he was bullying me too much. Yes, please. Okay.
My name is Douglas. Mine is more like a contribution. I am the information on the slides. I saw that the condition is autosomal dominant. So what I'm trying to say, I want to understand is that if it is autosomal dominant, that means that inheriting one can still give you the disease. So the capital T, small t can still give the disease. So that's the contribution.
Transcription.
Yes, based on the diagram, we said when you have the TT, you have the disease. That's what I'm
trying to explain how the crossing happens. But you can have the trait if it's autosomal dominant. If you have the small t, the abnormal, it can also manifest as a disease. Thank you very much for that.
Any more questions?
So what was once it's autosomal dominant, if it's autosomal recessive, then if you have the disease. Thank you for that.
Please, I'm Anita. I just want to ask, I was late, so I don't know how we begin, but from where am I just want to ask more questions. Does it mean that with this study, you are putting an implementation that this system, we are going to have the things to do, the labs, everything, or we are just learning it and we leave it for a research sake, or we are going to implement it? Then two, I want to ask, can that be sent to our churches? Because with marriage counselings and all those things, they do sickling, but they will not allow you to do this kind of test. So that's my question.
Thank you very much. I don't know. I don't have details of this grant. But normally, when you get a grant, the person or the institution giving you the money will give you the stages of the implementation of the grant. First of all, some of them will say, create awareness. Let people know. Let us see how many people you can involve in the awareness creating. Once you create awareness, then the next stage will say, okay, now you created awareness, probability, and we saw it from Dr. Pierre Kubi's presentation, is about 2.5%. So for every 1,000, you're going to get how many? Is it 25? 25. For 100, you're going to get about 3%. So first, we've identified, which is the first stage, that yes, it's a major problem. The next stage is to create awareness. Then you come to another phase where you now equipment to now start screening and start doing the lab test. Then once we do the lab test, we know that, okay, if I've got a trait, maybe I do not suffer I don't have early renal disease, etc. But then you know that, oh, okay, once you detect it in me, future can happen in my offspring. Then it will spread to the churches. So just imagine, you haven't heard about this, and then they brought a machine in your hospital. You see that it will be at corner, and then it will attract dust. Now they will crab baby make Cambron frame, because when I come to Ashanti region, and then people will be very happy. When you are parked in a corner, then it becomes useless. But if you know that, okay, I know this, I know we can use this to detect maybe the future, right? Then the next stage is to provide a. You can grant process if you don't know how to use it. No institution or organization will give you grant based on the fact that you don't know. So the stage we are is to create awareness, let people be, and then subsequently, we get maybe if Dr. Pierre Kubi say something on that. Now, have you written it for him? What we are discussing. Hey. No, not the churches, but the question was, the churches was just a supplementary one. The main question was, now that we are aware, where is the equipment? How are we going to detect it? How do we get the possibility of screening, which is important? Because if you create the awareness and there's no possibility of detecting it, then what is the need? So has the grant got a future of providing equipment to detect that?
Yes, I think this is detection we want to do, cut across the whole health area. And so when we get information on this, then we will know that there are issues that we ought to diagnose. Then the question is, how do we then get those instruments to do that? And that will call for another grant application. So they want to see the issue in Ghana, and then when we tell them the impact, then of course, that is why you could see that we are talking about West Africa, how to build a center, and these are all factored in. So it's in the pipeline. Thank you. So if we don't get this information, we aren't able to get evidence to back our case. And so we are developing the evidence straight ahead, and then we do further grant application to get stock what we are expected to do, especially with the diagnosis.
So my understanding is that this is the first phase to create the awareness. So once we get the awareness, and then the founder is going to see that Ghanaian and the West African colleagues are interested in knowing more and doing more, then there will be further grant to now get equipment to do the screening and do early diagnosis and early detection. Thank you. I think, Madam, I've answered your question. Thank you so much. Lovely. Yes, Miss.
What is about the penetrance?
What about
penetrance?
Genotype?
Yes.
Okay. I think, as I said, I'm a surgeon. Can someone help us, Doctor, about genotypes? But I think it's the same thing we explain. It's the same thing we explain.
I know when you say genotype, what comes to mind is whether AS or SS. But the word genotype is not peculiar to that. What they have explained now is also a genotype. So you are typing the gene to know the disease. The only difference between here and the AS-SS thing is that sickle cell is autosomal recessive. This one is autosomal dominant. And that was what somebody was mentioning, that if you have a small t, if it's dominant, it means that you can still have the disease. But in sickle cell, if you have A and a small s, or A and S, you just have the trait. You won't have the disease. That's the difference between the two. But in terms of screening, or in terms of finding out genotype, whether in sickle cell or in amyloidosis, is the same thing. That word genotype just means you are finding which gene is responsible. Right? I think that is clear enough. Thank you.
Thank you very much, sir. He's always rescuing me. We did endoscopy training. When I get stuck, as a surgeon, he comes in and tells all the genotype things in internal medicine. So once I done it, very grateful. Thank you, sir. Yes. So then I'll hand over to the organizers. Thank you so much.
Oh, you have a question? I want to ask about the 2.5 prevalence. Doesn't mean the study was initially conducted in Ghana to get the 2.5.
My boss is here.
The 2.5 is worldwide prevalence.
Okay.
The reason this work is coming to Ghana is to find the local prevalence in Ghana at the end of the day. Then, of course, the other West African countries, in Serra Leone, in Burkina, in Nigeria, in Côte d'Ivoire. Yeah.
Thank you, sir. Okay. Thank you.
All right, let's give Prof. Tabiri another. I hope we are learning. Yes. So he has just taken us through genetic counseling and then the screening. So at this point, I want to call Dr. Kubi to take us through screening for musculoskeletal and then what? The neuro-related Transthyretin Amyloidosis. So let's welcome him with a hand of applause.
Thank you. Thank you. Good afternoon. Welcome back. Yes. Amyloidosis. We all know what is going on. The question now is it necessary at all to screen? Is it necessary? And you know, to answer this question, we need to look into, if we know patient A has condition B, what next? What next? So the good news is that therapies and more are being developed. That is the good news. There are therapies, as in we have medication for treating Transthyretin Amyloidosis. But as I told you earlier on, amyloid proteins are deposited on organs. And earlier I mentioned drug targets. One would expect that if we have lots of deposits of amyloid fiber, transthyretin, we can get a medication that will wipe the deposits off. You see? Unfortunately, we haven't gotten there yet. So whatever is deposited, whatever effect the deposit has on us, we can solve that one. But then we can manipulate the protein to ensure that misfolding is what? Reduced or stopped. So you see why we need to learn about the disease. You see why we need to do some screening. As we progress, you will appreciate it. Earlier, I mentioned that we have analyzed systemic. And from all that we have been discussing, it is on what? Systemic. You see? So, that is good news. There is medication, but the earlier, the better. And we just mentioned misdiagnosis. This is the truth about the situation. Most of the symptoms or signs of transthyretin amyloidosis are similar to symptom signs of other non-communicable diseases, such as diabetes, especially diabetes. Okay. I don't know if you are much aware, but you see, if you have issues of diabetes now, sometimes, and I did mention that neuropathy is part and parcel of what transthyretin amyloidosis. Again, we mentioned syndrome, pain in the wrist or joint. This too is a disease by itself and may or may not have anything to do with transthyretin amyloidosis. But then what we are saying here is that if we realize that these things are happening, then sometimes we need to take a situation. Hence the need for us to screen. I hope it's clear. And in an attempt to screen, you will normally want to look out for what? Cues, signs, manifestations that will help you zero on or narrow your observations just to a particular. But you see, even when you, from what I talked about, we can develop a data of suspicion. You suspect that the patient has it. But until there is diagnosis, we can't start administering treatment. I hope you are following. We may suspect, but if we fail to diagnose, there is no way we can administer treatment because the medication comes with some challenges. In fact, if you use a medication, we will talk about that later, but it's good to mention it. If you use medication for AL, the light chain amyloidosis, AL amyloidosis for ATTR, the consequences will not be good at all. So, we need some indicators, some things that we can look at, and it might help us suspect and even get very close to diagnosis. So, when we were discussing the types of ATTR fiber, type A, type B, I mentioned C terminal, and I also mentioned and we tried looking at that information, and also about the transportation of thyroxine and what? Retinol. All these things, knowledge about them, it will help you figure out some possibility of bioindicator could use to strengthen one's suspicion of the condition. Let's now look at some scenarios. Say you go in to look for normal transthyretin protein in the blood plasma. Earlier I mentioned as normal levels. So below that, normal. And what it means here is that below that means some of them have been misfolded. So they go on that. We see misfolded, so they go on it. And so when you are looking or you measure and realize that it is below the expected or the normal value, it gives you reason to start asking, but what happened to the rest? Where have they gone to? And that might call for investigating into what? Misfolding. And misfolding here means you go looking out for type A, the fibrous morphologies that we talked about earlier, the forms of the fiber, to help you with some. So the question now is, I also mentioned Congo red staining. Staining is standard test for detecting amyloid fiber. But then, it is not specific. It will only tell you the amyloid fibers in patients. But as to whether it's ALEC2, ATTR, AA calls for what? Further testing. That is the intricacy involved in amyloidosis. So again, some of prevalence, disease or condition can what help. As we discussed earlier on, we now know that TTR V122I is with us. They have traced the source of this variant, West Africa. So it's West Africa. If we come to Africa, we know that countries have the highest prevalence of that variant. I mean, even looking within the sub-Saharan region, you realize on top we are leading. So the question now is, as for staining, it's an inexpensive, easily do in our part of the world. I only tell you there are amyloid fibers in the system, but what type is an issue? And until the type, we can't administer treatment. More harm to the patient than good if we start administering. So, if you recall, I did mention that. In fact, forget this. Our headache is or deposits of amyloid fibers of organs, and nobody really knows why. When we were talking, we did mention that some amyloid fibers or kinds of amyloidosis, you see that there is some to some extent, there is some limitations in the kind of tissues or organs you find low deposit on. Do you remember? Yes. And if you look at the list, you will see here discussing amyloid. It seems to have affect or actually most of especially the heart and then. So our focus should be early signs. How we detect, very, very important, because normally if so much life expectancy reduced to about just 3 years. 3 years. So detection is key. But you may also be asking me, but how many people have this condition? How many? So that there is a need for us to talk about the most likely event. We may be having cases, but not detecting them, or misdiagnosing, especially the heart condition. And the countries where there is zero don't have higher numbers. And so as we speak, we will be talking about that more. Diagnosis. When we get to diagnosis, we'll appreciate it. We just can't do or amyloidosis diagnosis in Africa. What we can do, I think we don't have the skill. But let's see the signs. First, this is an observation they have made, or research scientists have made. The deposits, you will find them musculoskeletal system, very early stages, and also in the skin. Somebody asked skin amyloidosis. To give us an indication that we need to do. So we said first, and we want to share with you the M3SM, where M is, and then the first S is skeletal, second and manifestations. With attention, chances that we were detect condition is very, very high. In fact, before symptoms or the disease to show that one can suffer bilateral in both wrists, tunnel syndrome. Before the symptoms of amyloidosis. So clearly, looking out for CTS, tunnel syndrome. Oh, the harm has not yet been done. much harm has not been done. So let's tackle it. Let's tackle it. I hope you got it for musculoskeletal. Even have deposits. You know, most of the deposits, to really get them, it calls for invasive approaches. Surgery. We can surgery. And so that has been discussed already. Red flags here are very good in that. Oh, it's early. So let's catch it as possible and deal with it. For neurologic involvement, as we said earlier, conditions are what nerve or heart related. Heart most because nerve heart those tissues or organs. So here, progressive peripheral neuropathy. With that, slow you tell if it is amyloidosis. Yes. So here, normally with cases of ATTR, slow. So gradually, even diabetes, but gradually. Amyloidosis, which one? Party. I include to do with the gastric. This earlier. Remember when something you will make more diarrhea will likely lead lost. Go down to kilogram level loss unexplained. You don't really, you are fasting. You like you have it. Something, one thing is not thinking, let's we did say those we mentioned, if they are, then normally it would one tissue, one organ. Look in some condition. Kidney. Did you tell them this? Yeah. Suspecting. This is what you should expect. Of course, this has and transporting them. You find more, and transporting them becomes an issue. So again, when and notice, don't forget, 75 kd and 55 kd, though we cannot see them, one is bigger than the other, isn't it? So one would expect that we are still on kidney, and we know the glomerular filtrate, how the kidney filters and substances that are expected to be in urine and not in urine. So still on proteinuria, it is possible that we will have higher levels of the retinol binding protein in urine. Possible. And when this is happening, we are not far from being right if we suspect that the TTR proteins are misfolding. So they are not binding. And you see, when the complex is formed, that one hardly can escape the filtrate because of the size. But with smaller ones, they seep out. And so we will find higher levels of them in our urine. So work is still ongoing, being done, to see how these molecules associated with TTR, you know, when you hear TTR, it means transthyretin. You don't want to mention the long one. You can just go with TTR. And that also helps you to remember the role of the protein, transport, thyroxine, and retinol. Yes, please. So, that is for, and invariably, the nephrologist will tell you, with these signs, it drives towards end stage of what? The kidney. What we call, or most of us refer to as kidney failure. So this is not epilepsy, but kidney failure could be a factor or an adverse effect of protein misfolding. Okay? Yes, please. Now we want to look into the eye. The eye. We want to look into the eye as well. So here, when it is the eye, we just say, oh, this is ocular ATTR amyloidosis. I hope we all appreciate ATTR amyloidosis. But I want us to think deep. If we say ATTR amyloidosis, is it hereditary or wild type? I hope you are there. Yes. What it means here is that we can have WT amyloidosis. So if you are reading literature and you see ATTR with a WT following, that is what it means here is that they have realized it is what? The wild type and not hereditary. But you see, when you see or realize that it is hereditary, you still need to want to know which of the variants. And with ocular ATTR amyloidosis, most of the cases are ATTR-V. Please, when you hear ATTR-V, what comes to your mind?
Variant.
That is a variant here. So, most of the cases of ocular amyloidosis are hereditary in nature. Please, let's do another thinking again. Recall or cast your mind back to TTR synthesis. Do you remember the eye is involved in synthesis of TTR? Do you remember? The eye also synthesizes TTR. The liver also does it. And which other? The brain. But we know that the liver does the bulk of the synthesis. And then the brain, the eye, they do less. In fact, less than 5%. So, what it means here is that even if the liver is not the cause of the misfolded proteins that are being produced, as in, even if we have a healthy liver, the fault might be with the eye. The TTR synthesized by what? The eye. I am bringing this up because the very first, it will be discussed. But you see, if we know that liver synthesizes over 95% of TTR protein, and we realize that the proteins that are being synthesized are what? Mutated. I hope you are there. That is the ATTR-V. If we get to realize that it is that one. Most best option is, before was to do a liver transplant. Liver transplantation. And liver transplantation here means that they look for a liver that will produce the normal one. Take out the one that is producing the mutant one, and then do this type of surgery. But you see, if you do the surgery, it might not prevent ocular amyloidosis from happening, unless you want to do an eye transplant too. I hope you appreciate the situation. It has also been realized that the transthyretin protein, there is an eye or ocular barrier between our blood system and that of the eye. So transthyretin protein does not cross the barrier into the retina. It doesn't. Are you following? Clearly, whatever happens in the eye is limited to what the eye produces. So let's look at some of the signs. What should we expect to see? See, I just gave you an example. We have talked about we realized 9 studies reporting ocular ATTR amyloidosis for the past 28 years. I will be giving you more details about this, I think, the last day. Right? Yes. It's a very, very interesting package that we will have to do a sober reflection over. Yes, very, very interesting package. So here, we found this, and there's no report of wild type. So, if you don't want to be specific, this and this is ATTRV. So I realized that earlier I disturbed you with precursor, but it's just to help us appreciate any differences we see. Because when I learned about ATTR amyloidosis for the first time, I had such issues. You will see some reports, the author is using P. Sometimes they don't even write a P. You just see them writing V14. They just write V142. Then you see another person writing V122I. And you begin to ask yourself, are they the same or they are different? Are you with me? That's why I took the pain to just help you appreciate the difference. One has to do with adding a precursor base pair of about 20 to 8. So if you look at all, you will observe some plus 20, plus 20. So when you see the plus 20, it is the same thing, except that, yes. Okay? Fine. Thank you. So we may move. We may move. Yes. I have explained. That is the BRB is the blood retina barrier. And the fact that transthyretin cannot cross, and all this I have told you, that we have discussed. So it gives a clue that even when liver transplantation is administered to a patient, we should still expect ocular amyloidosis to happen. And if you suspect ocular amyloidosis, next thing you should be looking at is this likely to be wild type or what? Hereditary. But what will be your guess?
Hereditary is V.
Yes, of course. And if it is a patient of West African origin, You won't be wrong if you want to say it's likely to be V122I. And if the person is of North America, South America, then you have an idea what to say. Not so, but you see, in the racial perspective, the V122I is black. Racial perspective, it is what? A black condition. But we have cases of V122I in Caucasians and whites. About 4 cases. When I say 4 cases, I mean 4 reports. Is that okay? 4 reports. So, what are some of the things we should look out for as signs or reasons to suspect? Dry eyes, one of them. So, just the visual opacity, cloudy visual. Normally in the right eye. Are you there? Normally in what? The right eye. And this we may not be able to tell why, but it is a trend that has been observed. And then we also have pupillary abnormalities. Very good examples are double vision. Also dropping eyelids. This, in fact, dropping eyelids is a very, very good sign. Very, very good sign. Eye motility is also not normal. And also an unnatural fundus appearance. Then this visual hemorrhage. But you see, if visual hemorrhage, diabetes is there. Sickle cell disease, visual hemorrhage is part. So you see why or what we meant when we said amyloidosis is associated with most non-communicable diseases. There is some link. And as we keep talking, we will appreciate it better. So, step by step, as we move away, I'm sure you will be fine, or we will all be fine. In fact, this is how bad it can be at the terminal stages. Blinding complication due to ischemic optic nerve neuropathy. So you see, a neuropathy again in the eye. And if you recall earlier, we talked about ATTR-V-PN, polyneuropathy. So clearly, it still goes to support that ocular amyloidosis is mostly hereditary and not associated with what? The wild type. And then also this. In fact, at this stage, you should know that we are having what? A lot of deposits. Chronic open angle glaucoma. Also in there. And this is a progressive optic neuropathy with characteristic loss of what? Retinal ganglion cells and axons. So the nerves are being destroyed or damaged. That is how bad the situation is. So we will always suspect that ATTR amyloidosis is critical in cases of unexplained progressive vision loss. If we can't really tell what the cause is, we might have done a host of testing on other causes of what? Such vision loss. And the test
none is positive. So if none is positive, but lost in vision, then we can start suspecting what? Ocular ATTR amyloidosis. The last thing we want to talk about is what? The heart. Remember, we are not saying that amyloidosis is limited to only these organs, but we have taken the pain to focus on them because they are the commonest, most affected nerves and the heart. So here, what are some red flags that seem to show or say that there is cardiac involvement in ATTR amyloidosis? We just talked about the eye, and if you look at the talk we discussed there, the whole thing is tilted towards where? ATTRV. Now we are looking at the heart, and I want to ask, I mentioned, but I want to ask, with the heart, is it more of ATTR, WT, or ATTRV? So yes, wild type is most common, but this does not mean that it is limited to only wild type. As we saw in the case of the ocular amyloidosis, with cardiac, we often have cases of heart, cases of nerve. And so, mostly, when we are grouping the symptoms or trying to classify cause of, when I say cause of, I mean which subtype of ATTR amyloidosis is likely to be behind the disease. We can say that, oh, this one is cardiac. We can also say this one is neurologic. And most of them, and when I say most of them, I am referring to the TTR variants. We have over 300 TTR variants. And that reminds me, not all the TTR variants are pathogenic. Pathogenic here means that not all of them really cause harm. Meaning that we can have TTR mutation that is not causing any harm to us. Are you there? We can have this. And so a question comes up. Is it possible that a patient can have more than one TTR mutation? Remember, we talked about, since we started, our focus has been on V122I and, I mean the variant, and what? V30M. Do you remember this? Yes, please. First, we will have lunch and then return to discuss the heart. Is that okay? Let's eat and then return to discuss the heart. Thank you.
Let's make the hand stronger. All right. Questions about Bagol. This mic is not working. Hello. Yes, so we thank Dr. Pierre Kubi for such a wonderful presentation once again. We want to take questions, so kindly put up your hand, write your question. I will come around and collect them, and then so that after the questions and answers, they will move for lunch and come back for the last part. We may be finishing earlier than we expected because we are tired, or some are tired. Yes. Any question, just raise your hand so that I will know that you are writing your
Please
question. I'll
ask,
come around.
We will manage. Ask.
Hello. Questions time, please. Have you written? Or I should give you paper? You have paper? Please write your question, raise your hand. I will come and pick it up. Then he will address it before we go for lunch. Are you stretching or you are raising your hand?
Are you with me? Are you with us? He is looking at target treatment for ATTRV. Frankly, the plan includes a brief overview of treating ATTR amyloidosis. We will say more, but the treatment or drugs available for ATTRV don't work for ATTRW. So yes, there are medications for ATTRV. And so issues with eye, we go for such medication. And in due time, we will learn to appreciate what these medications are. Okay? Thank you.
Any more questions?
Do we have a name for screening test for ATTR amyloidosis? Asking if we have a name for screening test for ATTR amyloidosis. Do we have a name for a screening test for TTR amyloidosis? That is the question on the floor. And the answer is this. It's just screening for ATTR amyloidosis. Just screening. Nothing special. If you go virtually, looking at what I mentioned about giving you an account of 28 years of report, it tells you a lot. We have that. So it has always been screening for that. And the screening is not diagnosis. Screening only helps us gather data on suspicion. And I am confident we know that by the time we leave here, as for data on suspected cases of ATTR amyloidosis, we are capable of doing that. We are very capable. But if we suspect and we decide to do the chip test, Congo red, it will still say, oh, there are fibrils. But the question now will be, which of them? And we are not alone. It is not only Ghana. That is why we are here. And when I say we are here, we have majority, because it is home-based, majority are affiliated with institutions in Ghana. But we have others from Burkina Faso, Guinea, Serra Leone, and Ivory Coast, isn't it? Why are they here? They are here to support us and to return to their home countries, to replicate what we are doing here. So together, we will be at the same level. But you see, when we get to diagnosis, you will appreciate that the infrastructure, the diagnosis itself is expensive. It's not cheap. And because it is not cheap, this is what happens in the global arena. They have centers where samples are sent for analysis and the results is returned to them to work on. That is what makes our project or our meeting here very, very, very useful and important. Mayo Clinic manages global bridges amyloidosis. The focus is, worldwide diagnosis of what? Amyloidosis. But can we do it in every country? We cannot. And fortunately for us, it just takes a blood sample to undertake genetic testing. Blood sample. So when you do the testing and it is negative, but you can still find fibrils there, then you suspect it is what? Wild type, and not a mutation. That's how it works. There's a question here. Can we use high levels of free thyroxine and retinol as early suspicion? Why not? We discussed that earlier. But you see, in science, especially the research angle, you need to collect data to substantiate thoughts. We don't have much data to support the need to look into levels of thyroxine, retinol in maybe urine or blood to inform suspicion per se. But that's why we are here. You know, it is not only we have people from the university joining us. What it means here is that it is not just about treatment, but also what? We are promoting research. And it is our hope that by the time we all leave here, we will embrace research. Personally, I have observed that case reports in our health sector is dropping. Do you get my point? Case reports is dropping. And it calls for boosting or encouraging those of us in the health sector to what? Embrace and do more research. What samples, yes, nice question here. What samples or sample will be used to screen for ATTR? Normally for screening, just by physical observation and urine blood will do. But we will go beyond screening to do diagnosis. And so, normally ATTR screening will only give you a reason to suspect, but it can give you a reason to start administering treatment. Are you there? We know that sometimes screening is used to mean diagnosis. You remember? Some screening is enough to inform treatment. But in the ATTR context, screening is limited. And diagnosis is key to administering treatment. I really appreciated what happened earlier. You know, I realized that it is just the beginning. But frankly, as we go, as we advance, you will be fine. And also ask questions that really pertain to the matter on the floor. Yes, please. Can we get an algorithm for screening of course, my clinic has one. Those on the WhatsApp platform, I gave you names of two important clinicians in my clinic who are supporting technically. Martha Grogan has an algorithm scheme for diagnosing. It's not even for screening. They have been able to use it to help diagnose cardiac-related Transthyretin Amyloidosis. So for the algorithms, use of IE, artificial intelligence, in fact, is showing promise in what? Even diagnosis. And you know how they do it. You just know the patient has it. And then you use your alternative measurements to see if it is giving you a pointer that, yes, that is it. That is it. And this one normally calls for gathering a lot of data. You have to involve a lot of patients and test significance of your findings to inform concluding that it is fine. And what you see. You see, that you may be wondering why they went that far. To diagnose, to do, we will talk about that. To do Congo staining, mostly it is biopsy. And imagine going to the heart to pick cells to look for amyloid fibers. So mostly, we have, it has been observed that the skin has chances that you will find some in the skin very, very high. So we pick from here, belly, and look. But it is not always giving us true positives. We will talk about that more tomorrow. Tomorrow will be diagnosis galore. Everything from start to end tomorrow is diagnosis. Yes. Thank you. I know this is for awareness, creation, but my question is, have we had a case in Ghana properly diagnosed? A very, 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 very important question. Yes. The answer is no. In fact, I pray that tomorrow the cardiologist will come. You know, I have interacted with a cardiologist, and I am hoping that he will be here tomorrow to talk with you. You see, this is how far they are able to go. I already told you. They are able to tell that there is protein misfolding, as in they do the Congo red. This happens in the teaching hospital. As for the regional and other places, I think some of us are hearing Congo red for the first time. Yes, please. But the teaching hospital, they do. So they are able to tell that, oh, but even medication they can't give. So they put them on fluids. Yes, that is the situation. Meaning that we have cases of what? Suspicion. And you are here, and for sure, you see, there's always, everything is step by step. When we started consultation, before getting you to join us here today, you go and they are like, this thing you are talking about, do you have a place where if we have cases you can diagnose for us? Do you have a place where, because the medications we will be mentioning, there's none in the country. But the good news is that one of our PIs, those in Jordan, they were able to get some medication from Pfizer. Not for sale, donation, to support patient care. So it is a process. And I also think that, so that is why we did the 28 years account. Just to help. In this account, you will learn about existing amyloidosis centers in the world and their contribution in those reports we will be talking about. You will see that it's unfortunate, but maybe it is this platform we will be using to draw people's attention to the fact that samples can be sent elsewhere for diagnosis or genetic testing. It is being done, but we are hoping that we will do one here for West Africa, for Africa. Yes, please. Help me. Sorry. Has any of you written something for me to read and respond to?
Any questions? Confirmed diagnosis is because we don't have the requisite place to do the diagnosis. So they can only do, yes, there is folding, but as to which one they can't. And that's why they have been leaving it at the folding side. Yes, with Congo red, they know that there is folding, but no further equipment to identify which one.
Has it been published yet? Not yet. It's the Yakubu part. You mentioned it to me before. Likely the two of them worked. There is news here. That Kolebu diagnosed a case of AL amyloidosis. And way back 2018. And yet to publish it as a case report. Very, very good. But like he said, until communication is out there, nobody will know. So You are telling us, but based on what is available, the answer is near zero. And I am happy to hear that even AL is the patient a Ghanaian? Ghanaian? But Ghanaian. Okay. But you appreciate why I asked? Yes. Amyloidosis, to some extent, the types, you can use it to predict where the person is coming from. That is why I asked this question. Thank you very much. Thank you very much. He's asking if CT scan can be used to diagnose ATTR. CT scans alone will not do. CT scans alone will not do. It is a combination. Okay? And we will talk about it. We will talk about it tomorrow. Big time. He wants to know if CT scan can be used to diagnose ATTR. Yes, but depends on we need to complement it with some other things to make it happen. Is that okay? So nice question. Thank you.
All right, let's give Dr. Kake a hand. Please, lunch is ready. We have red and plain rice at the right, when you go out your left-hand side. Then we have food down floor. The thing is, we are going to use coupons. So the coupons have been capsided outside. So when you pick, the coupon you pick, then please. So if you pick one and you don't want, maybe you just change with another person. Hello. Just have confidence that you are going to pick what you want. And if you pick and you don't want that one, just be sure that your colleague by you pick what you want and you pick the one, so you exchange. All right, so we can go out, pick the coupons, and then move to the various places for our lunch. Thank you. Please, we are using... It's 10 minutes past 2. If we are able to come back by 3, we can finish early. So you have 50 minutes to use for the lunch. from the lunch break? Has sleep started setting in or what? Yeah, so we are about to go for the very last presentation before we have an open forum. You appraise the session, then we close for the day. So the person to take us through screening for cardiac-related transthyretin amyloidosis is in the person of Dr. Daniel Ohime Menka. Let's give him a round of applause.
Thank you very much. And I'm pleased to be part of this very wonderful program. And for this last part, we'll make it a bit snappy because I don't want. I heard some people saying they enjoyed the fufu a lot. Some said the rice is good. So I don't want you to sleep, all right? So please, let's stay awake in this last part so that we can enjoy all the aspects of the program. I want to thank the organizers of this program for letting me have this opportunity to speak to you. I'm a cardiologist, so I'm interested in the heart. And it's always important that matters of the heart is always crucial, and it's very important, all right? And amyloidosis and transthyretin also loves the heart. Therefore, we'll talk about one or two things about the heart. An opening statement that I want to make is the fact that one of my professors I admire so much, he's on retirement, says that you cannot see what you don't know. And what you know really affects your suspicion. And so the moment you suspect is when you begin to look for it. And so for this disease, some of you may be hearing it for the first time, but don't think that the disease is now coming. It's been there in existence. It's just the fact that we don't find it because we don't consciously look for it. And I'm happy that this program is bringing the awareness of these kinds of diseases so that we don't attribute it to, in our setting here, spirituality, and somebody is trying to do African electronics to us. So, in terms of the heart, we all know and we've had information about the fact that there is deposition of fibrils in tissues. The tissues could be brain, it could be the heart, it could be valves, it could be chambers, it could be the muscle itself. And so that is what affects the heart. And amyloidosis and transthyretin affects the heart in a particular way. And it usually occurs in people with heart failures. And there are different kinds of heart failures, and the kind that is attributed to amyloidosis is what we call cardiomyopathy. And so when we say heart failure, it simply means the heart is failing. And therefore, the heart is not able to meet the metabolic needs that it's supposed to do. So the heart has got a function of pumping blood into the systemic circulation, and then it returns back to the heart. So the heart is serving both as a pump and as a reservoir. So if it's not able to pump well, it fails. If it's not able to serve as a reservoir where it relaxes for blood to enter, for it to be pumped, it's also a problem. And that's also another kind of heart failure. So these depositions infiltrate the myocytes, it infiltrates and is deposited on the valves, it infiltrates and it affects the conductive system of the heart. So the heart is just like this room. This room has got concrete walls, it's got electricity wires in the walls, it's got pipes in the walls that water flows through it. The same way the heart is. The heart has got muscles which are like the walls. The pipes with water flowing through are like the blood vessels in it. And the conductive system is the electrical current that moves through it. And amyloidosis and transthyretin does not spare any of these. It affects all those parts of the heart in their various capacity. And therefore, there are certain red flags that you may see in people who may be having amyloidosis from transthyretin. One is the atrial fibrillation. As I said, the deposit affects the muscles. So you realize that in the atrium, there's change in the muscles, there's change in the electrical current, and therefore you have atrial fibrillation. The atrium contracts haphazardly and is irregular. The patients will have heart failure. And we see a lot of heart failures in our community. We know hypertension causes heart failure. We know other cardiomyopathies causes heart failure. Coronary artery disease causes heart failure. But this kind of heart failure is usually progressive, and it has what we call preserved systolic function. So usually if somebody has cardiomyopathy with reduced systolic function, you realize that the ejection fraction, the fraction of blood that the heart pumps, is reduced. But in this kind of heart failure, the ejection fraction is normal or may even be increased. Yet you realize that there is progression in the heart failure because there is restriction in the heart, and the heart is non-compliant and is not able to pump well. We know that the classic heart failure person that you may see in the hospital may respond very well to some of your classes of antihypertensives. But this kind of heart failure usually do not respond to them, and they may even get worse, especially those with angiotensin receptor neprilysin inhibitors, angiotensin receptor converting inhibitors, and beta blockers. These evidence have proven that other people with heart failure, especially those with systolic dysfunction, respond very well to these medications. But that caused by this kind of heart failure, we don't have evidence to support it. And therefore, if you have a heart failure patient that you put on these antihypertensives and you realize that they start deteriorating, it should prompt you to think that you could be dealing with cardiac-related transthyretin amyloidosis. Those with sinus node dysfunction. So the moment a person is aging, amyloidosis is also associated with aging process. These proteins, abnormal proteins and fibrils, are deposited to the conduction system. If you remember your basic physiology of the heart and the conductive system, the sinus node is the pacemaker of the heart, where it gives signals at a rate of 60 to 100 discharge beats per minute. And that is transmitted through the atrium, it moves through the AV node, moves through the His bundle, and goes through the Purkinje fibers, and the heart contracts. So these fibrils also infiltrate this conductive system, and they may lead to various kinds of conductive dysfunctions like AV block. Person may get complete heart block, and the person may need a pacemaker. Can I get the next slide? There are other signs that would also show. And the cardiologists, we are interested in echocardiography and looking at the chambers of the heart. And amyloidosis, cardiac-related transthyretin amyloidosis, affects the valves. They affect the muscles, so the muscles become rigid. And sometimes it's even thickened, and it may look like other kinds of cardiomyopathies, where we have a genetic disorder where we call hypertrophic cardiomyopathy. And whenever we talk about cardiomyopathy from hypertrophic, we've heard of people who may be involved in football or athletes, and they collapse suddenly and they get sudden cardiac death. These infiltrates also infiltrate the muscles, and it may even become thickened that you may even think that it may be a form of hypertrophic cardiomyopathy. So if you see somebody with that, don't just conclude unless you have evidence that the genetic evidence that the person has the genes for those abnormal myofibrils that develop into the hypertrophic cardiomyopathy. But look out for it. Let's now begin to look out for those kind of things. People come, you do an echo for them, you realize that there's thickening of the interatrial and interventricular septum, and if it's thickened, this is more technical, you do an echo, it's based on what you see. And the cardiologist does echo almost every day. Today I've done about 3 before even getting here. But if you see muscles that are showing abnormal echogenicity, or you've seen a report that they said the muscles are showing abnormal echogenicity, please let's start thinking about cardiac-related transthyretin amyloidosis. There have been research to also show that people with aortic stenosis, which is also a degenerative kind of disease, where people with cardiovascular risk, old age may have it. However, autopsies have been done to also show that people with aortic stenosis and died, we did tissue biopsies and realized that those people on autopsy had these cardiac-related transthyretin in their blood, in the tissues. Next slide. The mitral valves too are not spared, so all the valves are involved. But commonly the ones that are involved is the aortic valve and then the mitral valve. So you do an echo or you do an investigation and they find out that there's mitral regurgitation. You need to look for other things that can cause mitral regurgitation. But one of them can also be related to this kind of amyloidosis. So I said that the conductive system is what controls and regulates the heart rate. And therefore, these infiltration can affect it. And some of them may need pacemakers if they have conductive disturbances. So you may hear of giving permanent pacemakers to people. And in Confanoche, we do pacemakers. In Kolebu, we do pacemakers. People also come with abnormal cardiac rhythms. irregular heart rhythms, and all these things affect the heart in its function. All right? People too can also have what we call autonomic dysfunction. People can have heart-related syncope. People collapse in the hospital from sudden drop in blood pressure. It can be from the heart not functioning well. It can also be related to autonomic nervous dysfunction, of which amyloidosis too is related in that same particular way. So you can have people with very slow heart rates, or people who may have irregular rhythms, or people with very high heart rates called tachyarrhythmias, and those with very low heart rate call it bradyarrhythmias. So the heart rate is slow. The patient may be complaining of palpitations. And you hear it a lot in the clinic, where you get old people come to say, oh, doctor, makuma bomi peri. You do all that you are doing, you investigate, you do Holter, the abnormality is there. Please, sometimes let's think about other things that may be related to transthyretin. Next slide. So there have been population screenings, and as Dr. Apiakubi said, we don't screen here. Some people even say it's rarely diagnosed. On the record, I remember about 5 years ago, one professor of mine is a hematologist. He diagnosed one. But I don't know whether he published it, and it was a friend of mine's father. But the man is gone into eternity. So we are not looking for it. But elsewhere, they have looked at it, and they have seen that there are different kinds of proteins or molecules and genes, and they are showing the various parts of how it is. As he said, the kind of transthyretin you are dealing with may give you a fair idea as to where exactly the person may be coming from. It can affect extremes of ages, where those with early onset, young people, and it can affect the extremes of people, old people. So the early onset disease in the first part of heart conduct is difficult to require, and it may require a pacemaker, while the second part, which is the non-endemic one, demonstrates late onset of disease with marked amyloid deposition. And they usually have what we call diastolic dysfunction. And I want to repeat again, the heart function both systolically by contracting and diastolically by relaxing. So I've said that amyloidosis causes restrictive cardiomyopathy, and the heart is restricted and is not able to relax to fill blood well. And these have been shown to correlate with long amyloid fibrils either in the subendocardial tissues and degeneration in the endemic populations with early onset, while the second population with the late onset usually have it. So we are trying to distinguish between two kinds: early onset, late onset, and their presentations are slightly different. It may be detailed, but in the clinical setting, all of them will group them together. But when you go to the molecular level, it's then that you can distinguish between them. Next slide. Notably, similar clinical and imaging outcomes, such as increased left ventricular thickness, is a predictor. When your left ventricle is thickened, it's a predictor of heart complications. And people get worried a lot. And of late, I've been getting patients who go to the UK embassy to do TB tests, and they find out that they are having cardiomegaly. Their heart is big, and all of them are scared, and they want to come and meet the cardiologist. Everybody is scared because when your left ventricular thickness is increased, it predisposes you to a lot of complications: stroke, myocardial infarction, heart failure, sudden cardiac death, and all the cardiac related and the comorbidities. Okay? And it's also been shown that people with aortic stenosis also get these kinds of left ventricular thickness. And it's also associated with cardiac amyloidosis, cardiac cardiomyopathies, and the heart not functioning well. There are other forms of cardiomyopathies that we hear of that may not be amyloidosis related. For example, what we call dilated cardiomyopathy, where the chambers will be dilated, but they will not be thickened. There's more of systolic dysfunction. There are other genetic ones too that are called left ventricular non-compaction. That one, by virtue of the fact of your abnormalities in the development of your heart, there is lack of or inadequate trabeculations or breakdown in the ventricles. So the ventricles, already the patient is born with that. And usually it's quite difficult to manage, especially in our setting here. But it's also another kind of heart failure that is also called cardiomyopathy. But what we are interested in most is what we call the restrictive cardiomyopathy, of which we call it infiltrative cardiomyopathy, of which cardiac-related transthyretin amyloidosis form part and is the key contributor of that. Next slide. So these presentations call for a thorough differential diagnosis. So you need to think about it. Have a differential diagnosis. Look at it. Is it possible that we are dealing with this kind of heart failure that you are having in your hospital? Can you discuss with your doctor or the doctor in finding out, is it just cardiomyopathy that we just stay there and wash our hands? Can we probe further? Can we look further? Can we have other differentials to look out for so that it broadens our scope? Okay? And more often than not, people meet physicians and they say, physicians deal with so many differential diagnoses. They list 20 and the patient dies. It doesn't matter. At least it broadens your mind and makes you think and think beyond the box. And so this calls for a thorough differential diagnosis to rule out heart conditions in diagnosing cardiac involvement, especially amyloid from transthyretin. So please, let's look. Let's now broaden our scope. This is Avenue is a platform for us to be aware of it and to look out for it so that we can find it. If you don't know, you will never find it. But when you know, you look, you will certainly find it. Next slide. So I think this is my last slide. So early suspicion and recognition helps in their management. And we've talked about, I'm sure the previous speakers have spoken about musculoskeletal signs and symptoms. You look out for it. Those with heart failure are usually those with the ATTR, the wild type, comes with preserved heart failure, progressive heart failure with preserved ejection fraction. And on the other hand, the ATTR V comes with more of nerve involvement, and you need to look out for them, especially those with autonomic nervous dysfunction, those who may have diarrhea, erectile dysfunction, which they will come and see the doctor. So you need to look out for all those old people coming with this, and this helps you in the screening of your patients. The last statement I want to make is that please, you must have that suspicion, and that will help you to look out for it, investigate it, so that you can make the diagnosis. Thank you very much.
We can do better. Matters of the heart are hard to deal with. I realized that when they started talking about the heart, everybody was quiet. All right, time for questions. Dr. Menka is around to clear our doubts. So just raise your hand. All right. Doc, you hold, then I send the other one.
Thank you very much. So this is not a question, but a contribution. It's like, I think one clear take-home message is that wherever you are, if you see a heart failure patient, and then it's a heart failure clinically, you pick the signs of heart failure. So you do your echo. And then the echo, you find the results of the ejection fraction, like he said, which will be normal. You get it? So then you don't know what is causing this heart failure with a normal ejection fraction. The obvious causes of heart failure, maybe you didn't pick them from your history and your examination. What do you have to think about? You can think about amyloidosis as maybe one of the causes. So that's where we have reached now. We want you to be aware that amyloidosis can cause heart failure. And therefore, when you meet heart failure and then the obvious cause is not staring at you, let amyloidosis be in your mind, so that maybe if you hear that there's any lab that you can do to test for amyloidosis, then that should be your next step, isn't it? And then maybe when we reach the gap that if you confirm your amyloidosis, medicines are around, then we can treat our patients. So I think that is the message we want you to take home. You see heart failure, no obvious cause. Can it be amyloidosis? Yes. Can I test for it? Yes. Then go ahead and test for it. Can I treat it? Then go ahead. Thank you.
Thank you very much.
Thank you, Doc. Please.
Okay, thank you. Doc, I want to ask this question. Erythrothrombosis. I want to know if it's a precursor for ATTR amyloidosis. And if so, what needs to be done? Thank you.
I'm not too clear about it. Is it related to the erythro what? Is it related to, I don't know what, is it related to the heart? Okay, how is it related to the heart? Erythrothrombosis. I've never heard it anywhere before. Is it blood related? What is it? I have no. I don't know whether maybe you are not saying it well.
What he's saying is a relative was admitted with a cardiac-related problem.
Okay.
And then they wrote erythrothrombosis there. So he actually, maybe
Frankly speaking, I don't know what he's talking about.
Okay, maybe he didn't get it well. All right.
Okay, thank you very much. Please, Doc, can you please go over the antihypertensives and heart failure in this case for us too. I want to ask a question, but then I want you to first throw more light on what you talked about initially.
Okay. All right. So, in treatment for heart failure caused by amyloidosis, the main principle behind the treatment is you treat the heart failure and then you treat the underlying cause, which is the amyloidosis, depending on what is causing it. Are you dealing with the AL type or the ATTR type? Good. So the principle behind treatment of heart failure is this. Based on the pathophysiology of the heart failure itself, in general, there are various pathways in the pathways. And these medications, especially those with heart failure with reduced ejection fraction or those with systolic dysfunction, evidence have proven that they benefit a lot from the angiotensin converting enzyme inhibitors. The ARBs, they benefit, and there is clear evidence in several trials that support it. Your beta blockers, which are cardioselective beta blockers, bisoprolol, carvedilol, they help. Spironolactone helps. Your diuretics help. But the heart failure caused by amyloidosis only benefit from the diuretics that you are given. But the ACE inhibitors, the ARBs, and the beta blockers do not have significant role. And there have been no evidence to back it that they've got mortality benefits compared to those with a systolic dysfunction. And therefore, if you give it to the patient, you would even rather reduce their BP and even worsen their heart failure condition. And so, in treatment, we don't give it, or we give it with caution. But peradventure, you are at a facility and you've treated your patient for heart failure with your ACE inhibitors, and you realize that with your treatment for the heart failure, the patient is even getting worse. Then it should prompt you that you may be dealing with heart failure, which is not systolic in origin, but rather diastolic, which is from preserved ejection fraction, and therefore you could be likely dealing with amyloidosis. And so it's just a screening or a way that you can assess, even without investigating, that you are giving somebody who is having heart failure, who should benefit from those antihypertensives, but rather it is making it worse. It needs to prompt you on that one. I don't know whether it's clear.
I asked because I read somewhere that patients who are put on beta blockers, the AC inhibitors, and most of the patients on calcium channel blockers tend not to do well on these medications. So when you said patients do not benefit,
you said 3 drugs. So you said calcium channel blockers, you said AC inhibitor, you are doing beta blockers. People with heart failure.
Yeah, no, in this particular case,
yes.
amyloidosis,
yes.
because of the risk of orthostatic hypotension, contractility, heart rate, neuropathy, and others. So when we said patients do not get benefit from it, I was confused because what I know of is, aside this one, patients do get a lot of adverse reactions from these medications. So that's what I wanted you to.
So what I'm trying to say is it's the same thing that I'm saying, but maybe you are saying it in a different way.
Yeah.
If somebody has heart failure and I know that it's from amyloidosis, I won't give them those medications. I'll treat them symptomatically with the diuretics. You get it? Because there's no evidence to support that it improves it. You get it? So if somebody who doesn't know, but is assuming that is the normal heart failure that we are having here, start treating and it gets worse, it should then prompt him that you may be dealing with that particular kind of disease. Okay? All right.
Thank you very much. I didn't understand it from the initial presentation. Thank you.
Thank you.
So thank you. I have a comment. During the echo, if available, using a global strain could help with diagnosis by showing a specific sign with a
longitudinal strain.
Yes.
Okay. Okay. All right. Okay. So in terms of diagnostic, echocardiography with what we call speckle strain helps, and I think is in the slides to come. So there are slides to show those kind of pictures. So there are classic echocardiographic findings that we will try and explain to each of us. It's more technical, but it's in the pipeline. So I don't want to take the wind out of the sail of the person who would present on that particular one. But there are classic echo findings that you see. There are speckle strains, there are cardiac MRI findings, and there are all kinds of nuclear imaging that you can do that could assist you in that particular one. So I don't want to take that one. Tomorrow, I'm sure we'll continue with that one. Please, the next question.
Doctor, thank you for your presentation. My question is, can a baby who was born with a congenital malformation of the heart, like tetralogy of Fallot, be screened later for cardiac-related transthyretin amyloidosis?
In terms of congenital heart anomalies, I would say those are genetic ones that has it. But if you have the suspicion that you think, based on the fact that a parent or a first-degree relative has, and you have the reasonable suspicion to take, and there are resources available, I don't think nothing should stop you from testing. But it's not been proven that cardiac-related transthyretin amyloidosis is a cause of tetralogy of Fallot. Tetralogy of Fallot is a congenital, and there are multifactorial things that could be related to the cause. But if you have a reasonable suspicion and you think you have the suspicion maybe from relative or some first-degree relative or first close contact or first close relative, and you want to screen and there are facilities, nothing should stop you.
Okay, thank you.
Thank you. Any more questions? All right. Let's give Dr. Menka another hand of applause.
Thank you very much.
We are drawing the curtains to a close. So this time is what? Open forum discussion for the first and second session that we had. If you have any question that you couldn't ask from Prof. Tabiri, Dr. Piakobe, and now Dr. Menka, you can still ask. Hello. Has the lunch started working? It has started. Let's shake it off by asking questions and contributing. Or you want to go and greet your best?
So, please, Dr. Aminka, so when you are treating your heart failure, which is maybe worsening on the other medicines, and you give only your diuretics, what next?
Thank you. So for treatment of heart failure related to amyloidosis, as I said, is two things. There's an underlying cause, and you treat the heart failure symptomatically. So it's been proven that diuretics improves the patients, because most of the patients come with, although it's biventricular failure, both ventricles are failing, but they usually show a lot of signs and symptoms of right-sided heart failure, where you have raised jugular venous pressure, you'd have hepatomegaly, you'd have bipedal edema. So your furosemide or your diuretics will help release the fluid overload. But the definitive treatment is to treat the underlying cause, which is the amyloidosis. And it will depend on the type of amyloidosis that you are dealing with. So if, for example, you are dealing with the AL, which is light chain, more likely related to plasma cell dyscrasias, multiple myeloma, then you should give your chemotherapy and treat those, the underlying cause. If it is from abnormalities from transthyretin, which is usually synthesized from the liver, then it means that you should treat it. There are medications that helps to manage and treat it. But usually, in facilities where they have the gadgets, if it's worsening and the heart failure is worsening, even though you are treating it symptomatically, you may end up having what we call both a heart and a liver transplant. Because if you do a heart transplant because there's infiltration, the liver will still be there and be producing the abnormal transthyretin. So they do both the heart and the liver transplant. But with general management of patients with heart failure with preserved ejection fraction, generally, there's not much evidence to support your AC inhibitors, ARBs, and your beta blockers. Unless maybe the patient may have other comorbidities like hypertension, at which you may introduce them, but you have to do it with caution. And that is very important, because most of the heart failure evidence, especially in the AC inhibitors, ARBs, support more of the ones with reduced ejection fraction. But there's not much evidence in that is related to the preserved ejection fraction. Thank you.
Thank you. So I would like to find out, at what age should you screen for amyloidosis? From all presentations, aging is a risk factor. So at what age should you suggest people, assuming all things being equal, we have the screening logistics in the country. So for most of the other cancers around, there are some age that has been tagged to them that when you get to this age, you should screen at once, twice in a year. So what age are we looking at, and at what frequency are we looking at? Thank you.
I don't think this is my question. Oh. Yes.
Thank you. Very, very important question. She did say you want to know at what age we can screen or diagnose. Call for testing. Please, the earliest onset of ATTR amyloidosis is 20 years. And that is the hereditary ATTR amyloidosis. For wild-type ATTR amyloidosis, the earliest we have recorded so far is in a patient in the UK, aged most recently 58 years. Earlier on, most cases of wild-type ATTR amyloidosis happen in the ages 65, in fact, most above 70. But as we chat, I think less than 2 years, 2017 thereabout, or less than that, UK recorded wild-type ATTR amyloidosis in a 58-year-old patient. They reported it and called for the need to look into considering using age 60 and above as the baseline for diagnosis. So 20. Thank you. But let me add this. From what we just said, we know there is a hereditary one. One can have the mutation, but not show signs of the disease. When that happens, we say you are a carrier. But you are not showing, not a patient, but a carrier. You see where I am coming from? From the career perspective, as early as even one, we can tell. But there are some ethical considerations. Prof. Tabiri discussed genetic counseling with you. It's a little bit difficult to want to diagnose at very early ages, say in the teen or less than 10 years old. But for now, symptoms of ATTR V has been seen or start manifesting at the age of 20 years. Is it okay? Thank you.
Hello. Thank you very much. I think Dr. Daniel Hinema or Himen Menka said it and made it clear that if you are treating someone with cardiac failure or cardiac problems, and you're using the generic, what is existing, and then you find out, you said it's what, the one with the high...
we have reduced ejection fraction, systolic dysfunction, and those with preserved ejection fraction.
So if you see such a patient, and you try the medication, you try all diagnostics method, and you are not getting results. And he made it clearly that, and he said it differently. I said, what the brain is not expecting, the eyes will never see. He said his professor says, could you please repeat it? That
what you don't know,
you
can't see it.
You can't see it.
And you can't find it.
You can't find it. So you have to think about it first. So you are doing all this to the patient in front of you. You are not getting what is expected using the normal practice. That should prompt you from today going that no, I should think of amyloidosis. Once you think about it, and if you have logistics to test and confirm, you do it, and it's positive, then it means that you now have to think about the family, the rest of the family. That is where the screening idea comes in. So if you ask me, that is what I would say. You have to first think about it, identify it, and then diagnose it. Once you diagnose it, you don't deal with that patient or that person in front of you alone. Then you have to go back and screen relatives and close relatives. So that is what I was at. Thank you very much.
Thank you, Prof.
Sorry, so if you identify the index person, then you want to screen the family, what's next? What are you doing for them? Ethically, maybe you screen, you find, what's next?
So that is why early detection, maybe, I think there is some treatment, you mentioned it. Early detection. Doc, is there a treatment as of today if you detect it earlier? Can you do something to prevent it?
Not that I know of, but I know that there are medications like for those
specifically to.
Yes, for that one. They have tafadimis or something. There's a medication I've seen, but I've never had
sir.
one in Ghana yet.
Yeah, there may be medication, but anything that has genetic mutation, you cannot really treat, you can only manage. So if I want to add to what Prof said about your question, when you detect it, from the teaching of today, especially his own, there are some other factors that will make it to present what we call predisposing factors. Some people may have the thing and they may live for 100 years, it will never show. So one of the things that we do is to cancel. No high blood pressure, for example, because we know it predisposes to it. If you have kidney issues, it can predispose to it. If you have liver problem, like he told us, can predispose. For example, if somebody has a trait and is drinking alcohol, you have to ask the person to stop, because the alcohol will affect the liver and it may cause more problems. So you look at what predisposes the individual with the trait in terms of organ system, and you cancel along the line. For the family, the way you have found out, you have to screen them. And I'm happy that somebody has been emphasizing screening and diagnosis. They are two different things. And sometimes we think they are the same. They are not. So you've got one person in a family, then you want to screen the others so that you can advise appropriately. Yes, for those that can be treated, you can support with the treatment, like was mentioned. But more importantly, since the disease has not shown, you don't want it to show at all. And so you cancel appropriately. These are the do's and the don'ts. And it's not just in amyloidosis, it's also in a lot of diseases that involve screening. Thank you.
Thank you.
To answer your question, what will you do? Somebody asked, oh, I understand one of you did want to know what one should do or will do if he or she is diagnosed positive or said to have ATTR amyloidosis. In fact, I think Prof. Tabiri mentioned it. This is what actually happens. If you detect that I have ATTR amyloidosis, and especially if it is hereditary, what most clinicians do is that they involve their relations. So they try to invite people who are close to them, talk with them, and take samples to see if they are carrying the trait or not. When they detect that you have the trait, the next thing they will do is, you know, the disease is young. Young, not as in when it started, but there are still gaps. A lot of work is still ongoing. So most of the times, positive, they will want to talk to your relations and take them through counseling, as in explain to them, and then take samples to check if they also have cases of ATTR. When that happens, they will keep an eye on you, as in they will make follow-up from time to time to find out if you are showing any signs of suspicion that the signs are showing, coming up and all that. And that reminds me, I mentioned, but I didn't answer. The traits say, is it possible that one person can have two variants, different variants? There is a case of that nature that was identified in the US in a Chinese. So where you have two variants in one subject or human being, when Prof. Tabiri was discussing genetic testing, I'm sure you heard about heterozygous, homozygous. Yes, there is a case of a compound heterozygosity. What this means here is that compound heterozygosity means that this is a patient that has one normal, one bad or abnormal genotype. But two of such, as in, you know, we have more than 300 variants that are pathogenic, disease-causing. They have found two of such in a Chinese patient in the US. Again, with the compound heterozygosity, there is an observation. We may talk about it as we advance. This is what they realized. In one case, the parent compound, you know what that means now. The patient, though one of the two is pathogenic, the other one was able to knock the pathogenicity off. As in, the patient, as a result of having two, didn't show any signs of the disease. There is the Chinese case I just mentioned to you. This same variant that knocked off pathogenicity in one, and that particular one is the V30M. We all know V30M or V50M is pathogenic, disease-causing. The other variant stopped it. There is another case where it is a different and not common pathogenic variant, pairing with the same variant that knocked off the V, and the patient is showing symptoms. So, a lot is going on. But unfortunately, we are not far.
All right. Thank you very much. I believe the first stage in addressing this condition is what we are doing now. And the next stage will be the screening. A screening that fails to screen ceases to be useful. I'm saying this in relation with when mammography was established and all females were told to go and screen. And radiologists were having challenges differentiating cancerous from non-cancerous breast. So I want to ask, how sensitive and specific is the screening for this condition?
Thank you. Please, my sister was asking the question about now she has been able to detect the symptoms in one of his clients. What next? So at the first stage with Professor, he was talking about how can we cut it off. Then we were doing the drawings with those who have it, the treat and all. So I asked the question that now if you have somebody, are we doing it for just clinical sake or we are going to prune it ahead? So he says, yes, we are going to prune it. So now we have detected. So why not using the detection to go through counseling from the drawings that we know that now, is this person we've detected, is it a career or is it a trait or is it having a full defect of the condition? So that's what I can say about
this one, let me say it here before the expert.
She's trying to, if I can take her words out of her mouth. What he's trying to do, I think there was a question, you screen, what next? And I think she's trying to elaborate that if you detect it and you see that, okay, it's going to run through the family, you can use it as an advice, counseling, genetic counseling. So if you don't know it, and Dr. Ohimen made it clear that you are treating, you don't even know what you are treating. And you tried all the existing and the standard protocol for treatment, and you are not getting results. Is it important for us to know and use the furosemide instead of using the ones we know which are not working? So knowing it is very important. It helps us in the counseling. It helps us to improve and also identify them before they develop the condition. So that if you have information about percentage of people with these conditions that run into the family, and then we have a health system that will be able to identify them. Definitely, if you know someone who has been diagnosed or who has a trait of sickle cell, and he marries and he gets a baby, and you don't wait. So you screen the babies at birth, and then try to mitigate the complications that will associate with it. Of course, you can't treat sickle cell, for example, but you can manage it. It can be treated. Well, okay. So it can be treated. And then it also helps you to have an idea what you're going to do next. Thank you.
Thank you, Prof. Hello. Any more questions? All right. Let's few announcements. Tomorrow, breakfast will be ready by 7 a.m. So we have 7 to 8 for our breakfast. Then we'll start our registration by 8:30. Then by 9, we'll kickstart. When we come early, start early, we close early.
Thank you. It's just a little concern. Today we didn't do any self-introduction. So we met our fellow participants outside and we couldn't identify them. So I don't know whether tomorrow it could be part of the agenda.
Hello. Yes, we are sitting without knowing each other. Yes, tomorrow we come in the morning. We didn't introduce each other, so we don't know each other. All right, there was a hand this way. So we'll do the introduction tomorrow. Was it the same thing?
All right, thank you. My question still goes to after diagnosed to wellness. But the question I want to ask is that there are conditions where when you, like some cancerous conditions, that when you detect, even if you detect it early, there are some cancerous conditions that even if you detect it early, you still have to watch and wait till you see signs and symptoms before you treat. So this, we've been able to diagnose, we go to the family and we've seen that somebody has some in the family. Do we watch and wait till we see signs and symptoms, or we can start something so that we don't even get to where signs and symptoms are showed? What do we do here?
I think once tomorrow we'll be going to the diagnosis, let's wait, so that if that is not answered. Yeah. All right, please, announcement. Let me give this announcement before I forget. We realized that many had concerns about the lunch. So they have made a list. When you go out, kindly write, indicate what you would like for to take for lunch tomorrow, so that we won't put the list down for you to pick again. So please, they are outside. When you just go out, write what you would like for lunch tomorrow.
Please, my concern is about the timing we are starting. It's about the buses who pick us up at our various hotels. If they come early, we'll come here early. So if we can talk to them.
All right. So if you are ready by 7, we'll also try to make sure that the bus is at your place by 7. Okay, the bus will come earlier. All right. So that will be sorted out. Tomorrow the bus will be early. There was a hand here.
Okay, so somebody is asking a question. Can amyloid transthyretin be a cause of chronic hypertension in pregnant women? A client with a hypertension who had pregnancy aborted after the expulsion BP persisted. Okay, all right. For the cause of hypertension, there've been there's no evidence to show that transthyretin is a cause of chronic hypertension. We don't have evidence to that effect. However, hypertension is multifactorial. There are so many things that we know are contributing to that. But as far as I am concerned, I do not know if ATTR is a cause of that. Thank you.
Please, can we have a volunteer to give us a closing prayer? A suggestion. After suggesting, you pray for us.
I'm a traditional man, anyway. With regards to writing our names for the food, I think looking at our number will delay. So can't we write on pieces of paper